he does his what used to be Cancer Regional Hospital in the community.
Yeah, Bob Canner, he's been around forever. There's lots and lots of CPR instructors in the community. You can go on to American Heart's website and just search for a CPR class and they'll all come up. There's lots and lots and lots.
What's the difference? You mentioned the AED class as well. Is that
Okay. So let me explain to you, there's two different levels of CPR. There's community CPR, which that's, you know, if you don't work in healthcare and you're just walking down the pickle aisle at Walmart, somebody has a heart attack, you can start compressions and yell for help. But when we're performing CPR as part of our job, we have to have a higher level of knowledge. So that becomes what we call basic life support, or BLS, which combines CPR with AED, which is an automated external defibrillator. So we just have to learn how to put the pads on, how to press the button on the machine. The button does all the work.
Okay, that's what
It's not hard, it's not complicated, it's not complex, and everything has pictures on it. So, you know, if you have to apply an AED, everything is right there to teach you how to do it on the fly. But as healthcare providers, we have to have a higher level of understanding. Okay.
April 11th.
Yeah, CPR Rescue and Ace Hope CPR are the two that. Ace Hope, ACEHOPE. She left some flyers here. CPR Rescue, she used to teach in this classroom, Julie is her name. And then she moved to Tennessee, and I've heard she's back. And I think that's probably who's doing it at the Fairfield. So she's, you know, very good. They're all very good.
Would you recommend for CNAs to do these first aid courses?
Depends on where you want to work. It's always a safe bet for CNAs to get BLS, which remember is CPR with that AED component, and first aid. Most employers are going to require it, but it really depends on where you're going to go to work. If you're going to go to work at a private, small 3-bed assisted living facility, they're probably not going to require first aid. If you're going to go to work at a mental health center, they may not require first aid because there's nurses right there on staff. But it's a good thing to have.
A lot of the jobs show that they want.
Most of the job postings will show that they require CPR and first aid. Everyone that teaches CPR will teach first aid, and they usually do it on the same day. Like the morning, basic first aid. Yep, the morning is usually CPR. That's basic first aid is burn management, heat exhaustion, recognizing the signs of a stroke, bleeding, stop the bleed, just basic first aid. Yeah, I can sum first aid up into about 2 minutes. If it's bleeding, put pressure on it. If somebody looks wonky, lie them down. If they're cold, if they feel cold, cover them up. If they're unresponsive, put them on their side. And if they're unresponsive, don't give them fluids directly in their mouth. Right, that's first aid. That is first aid. They're going to go into it in a whole lot more detail, but that's first aid. You're welcome. But don't stress CPR, don't stress first aid. They're not pass-fail classes. They're not going to let you out the door if you don't, they have to remediate you right there on the spot, right? So CPR, put your hands on the center of the chest, make sure your elbows are nice and stiff and push hard and fast. That's it. I mean, that's it. Hands only CPR, that's it. So there's not much there that you can mess up. But one of the things you definitely want to do is make sure the scene is safe. You don't want to be doing CPR on somebody while you're kneeling in a puddle of water with a sparking electrical line next to you, right? We're going to need to do 2 rounds of CPR, one on you and one on them. So you have to make sure the scene is safe. That just makes sense, right? I'll give you a good example of this. This happened to me about 2 weeks ago. I had walked into a dentist's office, my dentist's office, and I just told her, you know, my name, I'm here for my appointment. And as I'm standing there at the front desk, I mean, it's probably from you to the door, right? Very close. The door opens, and as the door opens and somebody walks in, I hear this huge bang. I mean, big, big bang. So she turns around and looks and says, oh my gosh, there's an accident. I got to the door, again, 2 steps. I get to the door and the car is still rotating toward me, coming this way.
Wow.
So accident happened. Literally, I didn't see the actual accident, but I mean, it's still going on, right? So one of the cars had been rotating. The other car was a complete rollover, had flipped multiple times. So I immediately run out the door. I've got my phone in my hand. I'm calling 911 as I'm running, because it would be like from here to the little road area right there. You know, I mean, it's a little bit of a jog, but not bad. So I got 911 on the phone, need to report an accident, you know, send EMS. I'm going to the car. As I get to the car, I throw the phone at somebody else that's just standing there. Here, talk to 911, because I got to figure out what's going on here. This one car that I had approached is upside down. Driver trapped inside. There's gas dripping. Is the scene safe? No, but neither is the patient. So the patient was trying, the victim was trying to get himself out. He was a young man, thankfully, reasonably unhurt. So he's wiggling his way out. I'm helping to pull him out. I'm getting him away from the car. He wants to get back in the car to get his phone. We don't need to be doing that. There's gas dripping actively. Scene is unsafe. So at that point, I mean, he's upright, he's in shock, but he's, you know, doesn't appear to be overly injured to the point that I need to intervene. I can wait for EMS to get there. My job now is to keep him from getting back in that car because he's in shock. He's not thinking rational. Just wait till EMS gets here, and then somebody can get in your car. Maybe somebody that has a fireproof suit on can get in your car to get what you need, right? So making sure the scene is safe, pretty important, because you can't count on the people that are affected to make the right decisions because they're in shock. They're not thinking clearly. So that becomes your responsibility, your task here. If I had noticed a broken bone, I would try to get him. Guys, I can tell you, a lot of people will walk on broken legs in an emergency situation because they don't feel the pain. They're not aware. They're just not aware. It's not until that adrenaline, best painkiller in the world, covers everything, everything. So until that adrenaline wears off, they're not even going to be aware that they got a bone sticking out the side of their leg. So your job is to notice, because you don't have that same level of adrenaline, is to notice bone. Let's get you sitting down, right? I can't really do much. I don't have a splint on me, right? There's not much I can do, but I can put some pressure there to try to limit the amount of blood that you're losing. So when we get you to the hospital, they don't have to import blood, right? So I can at least do that much. So first aid is all about trying to intervene where you can to limit the amount of damage that's occurring.
Does the Good Samaritan Act come into play, like in the scene?
Absolutely.
So you, as a Good Samaritan, responded. If there had have been a broken bone, and the safety is to get the, in your situation, the victim out of that car with the gas leak. You got them out, the bone shifts worse in the getting them out. On, like, not meaning to, but it does, they cannot turn around and try to sue you. So
No.
we're in a sue happy world.
Yeah, no, we're definitely in the litigious world. I mean, there's no doubt about that. But no, the Good Samaritan law does cover you. And any lawyer in the world would say, well, better a broken bone than a dead body. Because at least you're, now you're alive. If the car had caught on fire and nobody got you out, we wouldn't be having this conversation. So you better thank them. Because you would have had that broken bone regardless.
I know you may have one, two, first, second, or third degree burns to go along with it.
Or smoke inhalation, or, I mean, there's a million problems with that. Plastic, plastic burning tends to drip. Yeah, there's a lot of very serious consequences there. So yeah, getting him out doesn't matter. I mean, even if he had a back injury, getting him out of the car, because it's an emergency situation, we have active gas dripping, would be prudent. I mean, I'm not going to go to the patient's family and say, I'm so sorry that your son died. I would have tried to get him out of the car, but I thought maybe he might have a neck injury. That's no consolation, right? No consolation at all. No, I'm happy you let my son die. Thank you. So no, the Good Samaritan law absolutely covers you as long as you're operating within the level of your training. Now, let's take that same situation. Let's say that at this scene, I pull this guy out. He is not breathing. He clearly has a traumatic injury to his neck. And instead of doing CPR, I pick up a ballpoint pen, I unscrew it, I get the little column here. I take a pocket knife out of my pocket, cut a hole in his neck, and stick this in to try to make a trach. Is that, do you think, within my scope of practice?
No.
Is that something you think I was trained to do?
Yes, us no.
No, actually, for me, it's not even something I was trained. No,
Oh.
no. Yeah, under anesthesia, never in the field. I mean, unless you're like in Ukraine. Now, that's the only place that might be relevant at the moment.
I thought EMS and paramedics had it. In emergency situation.
Yeah, not EMTs, but even still, they're not doing a field trach. They would intubate, just take a tube and put it down the throat, but they're not doing a trach in the field. Absolutely not. We have no suction. Do you know what happens when you cut something? It bleeds.
Oh yeah, and then you're gonna ask for it.
Yeah, so we have no suction material. Do you know when you cut somebody, it hurts? We have no anesthesia. This is just not, this is not a plan. Not a plan. Why do you think I'm giving you this scenario? Yeah, I've seen it. Legit happened. Yeah, don't do that. Don't do that. Okay. CPR, yes. Do CPR. If all you're doing is hands only CPR, that's okay. That you're doing something, CPR. If it's been more than 6 minutes and you think you might want to get a breath into the patient, that's awesome, right? Because it doesn't do you a whole lot of good to keep circulating blood if we're out of oxygen in that blood, right? So, a couple breaths now and then, that's good. If you forget, oh my gosh, is it 30-1 or 15-2? I can't remember. Just do the best you can. We're pumping on the chest to circulate the blood. We're blowing in the mouth to give them some oxygen while we're circulating the blood.
The chances are the 911 operator is going to walk you through it.
Oh yeah, absolutely. They have a book in front of them that they literally read from. So it's an open book test, guys. Open book. The 911 operator is going to tell you what to do. So it's okay. And you're not doing this forever. You're just doing this until, a more qualified individual shows up. That you're just trying to like, just, yeah, just like, I'll do what I can, but I'm looking for mom. I need an adult. Somebody get me an adult, somebody that knows what to do here, because I can only do so much. As long as you understand that, that's exactly what you're supposed to do. So don't get, everybody gets like super stressed out over CPR and first aid. Guys, it's the easiest classes you'll ever take. They're information classes. It's not a pass fail. Yeah, you got to demonstrate it. Sure. I want you to show me on the dummy how you would circulate my blood if I'm the one on the floor. Can you do that for me? You know, if my heart just stops, can somebody please, you know, jump on my chest and call 911 to get the adults here to figure out what to do? That's what we're looking for, right? So make sure the scene is safe, call 911, and please make sure the patient is like truly needs CPR. I saw this happen at a dollar store. A patient fell, was talking, and somebody came up and said, I know CPR. Well, that's great, but we don't need it. She's talking. And just because somebody falls doesn't mean you get to practice. Hey?
Right.
Yeah, I know CPR. No, you clearly don't, because your patient is talking. They don't need that. So you clearly don't know CPR. You don't.
Well, on a safety note, since we're kind of touching that, but I was reading in chapter 2, I think it was, yeah, chapter 2, about the seizures and what the CNA would do if they walked in and a patient was having an active seizure in bed. In a facility, you could be, okay, I'm gonna use this term. Your patient could be over in that empty chair over there. The closest nurse might be on this end of the hallway. And it says, don't ever leave the patient alone
Right.
having a seizure. If anybody's been to see anybody in a rehab, a skilled nursing facility, even a hospital, that call light, you may be the only one on that hallway. The nurse is busy. They may not see that call light. Go
Well,
on.
you're not going to hit the call light because you're the one that answers the call light and you're already there.
Exactly. So in that scenario, and your hall partner is busy feeding Mr. Smith in his room, what would you do? Because you're not technically supposed to leave that seasoned patient alone. You're supposed to yell for help, but the closest person may be at the very other end of the hallway.
How loud can you yell?
I guess I can probably yell pretty loud.
You'll find out. You'll find out how loud you can yell.
Okay.
But
So
I
stay
guarantee
with them.
you, oh my gosh, stay with them.
Okay.
Stay with them. Stay with them. That's what you need to do. That is your number one priority, because you don't want that patient to fall off the bed, to hit their head.
Exactly.
Right? So your job is to stay. You also want to time the seizure, because we make treatment decisions based on how long the patient was seizing.
Just
3 seconds, way different than 30 minutes. Okay, way different. We need to know. We need input information. I can yell pretty loud. I guarantee you that if I had a patient seizing and there was another staff member anywhere on the unit, they would know. They would know. But not only would a staff member know, do you know who else is going to hear me? Absolutely. And don't you think that they're going to intervene because it's an emergency? They'll start saying, hey, nurse, the girl needs you.
Or they'll call.
Right. So, yeah, in an emergency, that's not the only person that's hearing you. Everybody. But you also have to think about all the staff members, right? Yes, it may be you and a nurse, but there's also housekeeping. Dietary may be on the unit. There's a doctor making rounds. There's a unit secretary. There are way more staff members there. It's not just you and one nurse. There's a million other staff members that are in the unit too. So yeah, you need to yell for help for sure. And somebody is going to hear you, whether it's another patient, whether it's the nurse, whether it's other staff members, somebody's going to hear you and intervene. The only time that this doesn't help is if you're in a home care setting and it's just you and them in the house. Now that's a problem, right? But chances are, if you're in a home care setting, you probably have a cell phone in your pocket. So instead of yelling out loud for a nurse, you should be calling 911 and saying, oh my gosh, I'm here with my patient. They're having a seizure. This is new activity. I don't know what to do. I'm here with the patient. They're not injuring themselves. What do I do now? Now, if the patient is a home care patient and it's just you and them, and they have a known seizure history. Yeah, I have seizures. And when I have a seizure, please don't call 911. We know I have seizures. Just time it and keep me safe. Right? So that kind of looks more like a care plan, doesn't it? So patients that have seizures on a regular basis, they generally don't want to go to the hospital every time they have a seizure, because if they could have fixed it, they would have done so 15 trips ago. Now, all I'm getting is a bill. You know, so, and, you know, if you're at Walmart and somebody's having a seizure, call 911. But when the patient comes to, they may refuse to go. That is their right. Yes, you just witnessed a seizure. You're probably more traumatized than they are. If they have a seizure disorder, this is normal to them. They don't need to go to the hospital. Make sense? So understand that your level of comfort with a condition may be completely different than the patient's level of comfort.
When I was, my cousin was driving, he had a seizure while he was driving.
Oh.
And I was in the passenger seat on 50. So like I was in panic. So the first thing I did was just turn the car in the middle of the median and I just put the car in neutral. Thank God I put the car in neutral because his leg went stiff and he stepped on the pedal.
Yeah.
So the engine blew because he was just having a seizure, you know. I just got out the car and waved. Thank God it was an EMS driving by. He pulled over, he came, helped us out.
Wow.
It was crazy. You know?
Yeah.
He was like, I see a light, and then all of a sudden he just starts seizing by driving.
Yeah, he's like, yeah, all right. Had he ever had a seizure before, or was that new?
I think it was new.
Yeah, in that case, we definitely have to get him to the hospital because it's new. So what caused this seizure? You know, is there an underlying condition there that we need to know about? If you have a known seizure problem, you know, you've had seizures many, many times, driving is probably not the best activity, you know. But yeah, it can be, oh my gosh, that could easily have turned into a tragedy for sure.
Like the first thing I was like, all right, I'm just gonna put this in neutral.
Yeah, no, that you did the best job possible. Yeah. Yeah.
Like if anything ever happens, my mom always told me if someone has a heart attack in a car or anything, always put the car in neutral.
Yeah.
Anything like that, because they can't do nothing.
Right. At least you've moved the speeding bullet out of the way. This just happened to a school bus last week. The driver had a medical emergency. I don't know what kind of emergency, but the driver had a medical emergency. And two of the children, well, I say children, but they were like 16, 17. They quickly intervened and got the bus in neutral and steered it off of the road to save all the kids in the bus. So yeah, I mean, that you definitely have to be aware. Good job. That is awesome.
I was only like 20 years old too.
Oh, scared. Yeah. Oh yeah, for sure. Definitely scary. So are you guys starting to get the idea of an emergency, responding to emergency is just to try to make it as safe as possible until somebody else gets there? And if you're not calling somebody else, like if you haven't picked the phone and called 911, you're going to be there by yourself for a very long time. So like the very first thing you got to do is get help. Call 911. As you're running, call 911. Okay, good. That's first aid in a nutshell. Call 911. All right, so any questions on your homework other than that? Any other questions on your homework? You had chapters 2 and 3 to do over the weekend. Questions? Linnea, do you have any questions?
Not really,
Okay.
but I was wondering about the military time.
Okay, so military time. Let me find that page for you. I have a page for that. Page 29 in your white book is a activity page on military time. And we use military time in healthcare because we operate 24 hours a day. It's not like a bank. If you walk into a bank and say, I need to make a withdrawal at 1, they know which one you mean because they're only open during the day. But if you walk into a hospital and say, I need to prep a surgery, prep a patient for surgery at 1, that could be 1 in the morning, 1 in the afternoon. We need something a little more concrete. And AM and PM, when you're writing them, can actually look a whole lot alike because they both have a circle. So it's in an effort to prevent medical errors that we use the 24-hour clock. But for me, this always made sense because how many hours are in a day? 24. Who was the bright person who said, okay, well, we're only going to count to 12 and then we're going to start over again? I mean, was 24 really too much to count? There's 24 hours, so we're only going to count 12 of them and then we'll do it again. Why? That never made sense to me. I mean, why? So military time is just, we have 24 hours, let's use them all. That's it. That is military time. 24 hours a day, we're going to use them all. So instead of getting to 12 and starting over, we're just going to keep going. 13, 14, 15, 16, 17, 18, 19. We get to midnight. Well, that starts a new day. So midnight's going to be 0. So the military time is the hour, 1 to 24, right? 1 to 23, the hour, and then the minutes. Mush them together. No dots in between, no AM, no PM. Just mush them together. 4 numbers mushed together. Okay, so 4 in the afternoon, 4 o'clock on the dot in the afternoon would be 1600, 1600. For 12 in the afternoon would be 1612. 4 in the morning, well, wait a minute, we need 4 numbers all mushed together. 4 in the morning, we don't have 4 numbers, so let's add a 0 in front. 0400.
It seems
Good.
pretty easy.
It is. Once you realize that, oh my gosh, there's 24 hours a day, let's use them all, military time becomes pretty easy. I still want to know who the guy was that would only count to 12. I mean, who pitched that idea? Can you imagine? Okay, listen, guys, I think the counting to 24 is just too hard. I think we should just do it to 12 and then start over. And somebody said, well, how do you know which one? Let's put some letters in there. Yeah, letters go with numbers. Let's do that. I mean, who pitched that idea? I'm a fan of military time. In
I
case
set
you
my
have.
phone to the military time 24 so I can learn it faster.
Yes, you can do that. Your phone will definitely help you learn military time. And there are clocks that do both military and what we call regular time. You can see that there on page 29. You can see the clock in the first column. You'll see that just below the 1 is a 13, just below the 2 is a 14, just below the 3 is a 15. A lot of healthcare settings have clocks like that. So it's very easy to, to look and see what time it is. But for the hour, it's simple. If it's 4, you just add 12 to it. Because remember, we kept going after 12. So we're just going to add 12 to the hour for the afternoons. All right. So that helps, Selenia? Did that help you?
Yes, thank you.
You're welcome. How did you do on chapters 2 and 3 so I can write down your grades?
Let me go to the back. I marked it down.
Yes, it's page 133 and 134. I'll be asking all of you.
I got an 85.
85 on 2?
Mm-hmm.
And what'd you get on chapter 3?
And chapter 1.
Chapter 3?
Three.
I'm sorry, I think I'm losing you. It's bad connection. Can you say that one more time? Yeah, unfortunately.
3 or 90.
If you can type it in, because your voice isn't coming through, just type it in the chat for me, please. Olivia? Thank you. Fa? 4 on each one?
No.
Okay, how many on chapter? Okay, 2 more on chapter 3? 1, okay. Do you have chapter 1 done as well? Somehow I'm missing that. How many did you miss on chapter 1? Okay, very good. Kat? Thank you. Ray? Thank you. Ray, can I get chapter 1 from you as well? Thank you. Millie?
I didn't quite do chapter 3.
That's okay. Very good. Very good. I'm not that kind of a teacher. It's okay.
No, it's not. I didn't even notice.
Sierra?
A 90 on chapter 2 and a 95 on chapter 3.
Thank you. And Rachel? Not here. All right. So any other questions? Anything I need to know? Anything I can help you guys with? Thank you, Selenia. Is that's for chapter 3? Got it. Okay. All right. So any questions on what we went over in class on Wednesday? Any questions on Wednesday? No? Let's see if we have learned anything. How do we know what to do with each patient? Care plan. So we follow the care plan, the whole care plan, and so that means we can't change it. Can't add to it. Can't come up with our
Nothing
own.
but the care plan.
Right, nothing but the care plan. If you notice anything while you're performing those tasks, what do? Yeah, notify the nurse, absolutely. And what if you can't do the skill the way the care plan tells you to? Okay, ask for help. But who do we talk to? The nurse. Okay. Can you be trained in other skills later on wherever you go to work? Okay. All right. And what if a nurse asks you to do something you've never been trained to do? Tell them. YouTube. No.
No.
Yeah, no YouTube. Tell the nurse. Very good. They may use YouTube to train you, but that's not your job. Every skill starts with the opening, but what does every opening start with? A knock. Yeah. Yep. And yeah. And then once you knock, how do you know you have the right patient? Yeah, you can ask them, or you can notify, or you can call them by name and they'll let you know if they're not. What does the patient have to know about you?
Your name,
Okay, your
who
name
you are, what
and
you're
your
there for.
title and what you're doing. Very good, very good. Good job. You're going to tell them all of that because you need something from them before you touch them. What do you need? Permission, consent. Very good. Once you get that, you can close the curtain because now we're ready to go. Once you close that curtain, what are you going to do? Well, why? Curtain is not clean. Very good. Very good. And then once you have clean hands, now you can get your supplies. But you got to have a place to put those supplies. Where are you going to put them? On a clean surface, which is a barrier. Very good. So we need a clean place to put our clean supplies. So we're going to go get a barrier. Should we get all of our supplies at the same time, the barrier and everything we need? Why? Okay. Yeah, you don't want those supplies to touch your uniform. Why? Yeah, contamination. You're dirty. Absolutely. So we're going to go get the barrier first. Then we'll go get all of our supplies and put them on the table. Should you get your supplies before your opening? Why? Okay, doesn't give them the option to refuse. Is there another reason maybe? Okay. Yeah, it kind of goes with that. But if you get your supplies before you walk in the room, have you washed your hands yet? So you're touching those supplies that you're going to use on a patient and you haven't washed your hands. Guys, this is a very, very common mistake made on the test. Very common. Everybody wants to go in and get their supplies before they do their opening because they're thinking about, they don't want to make a mistake. They're thinking about those supplies. Uh-oh, she left. Let me see here. Oh, okay. Okay, good. All right. So we have to do this in the right order so that we're not accidentally contaminating the supplies that we're about to use. So the order here is really going to matter. Should we wear gloves for every single skill that we do? Why? It's a whole lot easier. Man, if you just walk in a room, you don't have to think about it, put your gloves on for everything that you do. That's a whole lot easier. Why can't I do that? Okay, you stop paying attention to what you're touching with those supplies, and we are going to contaminate. That's right, cross-contamination. It happens all the time. And you'll notice it. When you get out there and you start watching other people, how they do things, you're going to go like, oh my gosh, do you not know? Chances are they don't. Don't be too hard on them because you didn't know that before you sat in this class either.
COVID, everybody had the healthcare. There was such a shortage that they had one respirator unless they were in a COVID isolation area. But even now, because I had to take my husband a couple weeks ago, I noticed every staff member had a mask and they wore that same mask from room to room to room. You could watch them. That right there is cross-contamination right there. At least I think so.
Well, it is, but it's no different than your uniform that goes in and out of every patient's room. So it's kind of like just an extension of your uniform. Now, the problem with the mask, and I said this when COVID first hit, right? When COVID first showed up on the scene, there was a problem because we ran out of supplies very quickly. I mean, very quickly. And it used to be prior to February of 2020, you did not wear masks or gloves or gown outside of a patient's room. I mean, that was law. And if you got caught leaving a patient's room with these items on, the facility was fined, right? So this is a really, because it has to do with that cross-contamination, right? So COVID hit, and now all of a sudden, JACO, who they're the ones that make sure everybody does everything right, JACO's like, oh, well, we don't have enough supplies, so it's fine. It's fine. So what wasn't fine 30 days ago, all of a sudden became fine because of the situation that we're in. So we need to understand that, yes, these ideals are important, and we're going to do everything we can to minimize the cross-contamination, but they're also going to be dictated by circumstances. I can't tell you to take the mask off if I don't have another one for you to wear to go into the next room. So we have to be adaptable and change as the situation changes as well. And there were a lot of nurses that just, kind of threw up their hands and said, well, wait a minute, if it wasn't good then, it's not good now. I'm not doing, that doesn't help. That doesn't, I get it. I do get it, but we still have a room full of patients to take care of. If we don't have the supplies, we got to improvise. We got to do the best we can with what we have. So be adaptable. The reason that I teach you these principles is so that you have a good understanding of infection control, so that when they offer solutions, you're able to kind of reason them out and figure out whether this is going to be an acceptable risk for you. Okay. And then we just flat out went to like bandanas, which just, okay, that's a stretch. Yeah, but it's all about droplets, right? Because at first we thought COVID was airborne. Now airborne is worst case scenario, because airborne, that means the stuff kind of stays in the air, in the air. Right. So at first we thought it was airborne. We also thought it was contact. That's why they told you, if you're going to the grocery store, wear gloves, which is silly, but we now know that it's not contact. And that only works if you understand infection control. And after you've touched the ketchup bottle, you then take the gloves off before you go to your car, because otherwise, if it is contact, you just spread it everywhere. But I teach you these principles because it's important that you have a baseline to work with. Okay. So we're not going to wear gloves for everything, because that's just bad form. But there are going to be some times where we do need gloves. So how do we know when we're going to need gloves for a skill? There's 3 rules. Anybody remember what the rules are? Okay, so body fluids are ooey gooey, yes. Non-intact skin, yes. And this is the one nobody ever remembers. Nobody can remember the third one. But if I was at a beach, I would be, yeah, I would be covered. All my, private areas would be covered sufficiently. So ooey gooey, personal skin, non-intact skin. If the answer is yes to any of those, you need gloves. If the answer is maybe to any of those, you need gloves. If the answer is no to all of those, you're going to wash your hands before and you're going to wash your hands after, and that is sufficient. But regardless, if you wear gloves, do they keep you 100% safe? So once you take those gloves off, what do you need to do? Wash your hands, because something got through. I guarantee it, something got through. Don't skip hand washing after glove use. Okay. It's probably more important, because remember warm, dark, moist? probably more important. If you're going to skip any hand washing, probably the one where you didn't wear gloves is better. Don't skip any, but at least it's not a warm, dark, moist environment for those pathogens. Okay, make sense? We're also going to learn how to remove gloves correctly in just a minute. If the patient's going to be uncovered or undressed, what do we need? Privacy blanket. Why? Okay, we don't want anyone to see them. They don't want anyone to see them, including, right, correct. Is there a temperature difference between the way I perceive temperature in here and the way you perceive temperature in here? Because I'm fully clothed running around like crazy and you are laying in bed in a thin hospital gown. So we need it to be warm for them. Okay. When we're putting a blanket on, do we snap it or shake it? Why? Yeah, ooey gooeys, man, pathogens, yeast particles, dead skin cells. Man, that is not appetizing at all. Okay. Did we go over? Yeah. So we went over scoot and roll as well. Did we go over scoot and roll yet? No. Okay. All right. I apologize. I was doing questions on the online course this week. So I was writing questions for all these. So now I can't remember what I've taught you and what okay, so we did dressing. Okay, so privacy blanket. When we're dressing a patient, how do we know if they have a weak arm? How do we know which arm? Okay, care plan is going to tell us which arm is weak. Does that affect how we dress them or undress them? So how do we know what to undress first? Okay, so USA first, undress strong arm first. Very good. Very good. If somebody has a weak arm or an affected shoulder, is it easier to use pullovers or snap fronts? Anything that fastens in the front. Very good. All right, and then every skill ends the same way with the closing. There's 6 C's to the closing. The first 4, the order doesn't matter. Can somebody tell me any of those 4? Any of them? So clean environment, comfort, curtain, call light. Okay. Right. So those 4, the order doesn't matter. Comfort, curtain, call light, clean environment. Doesn't matter how you do them. Get them done. Find a way to remember them. Comfort, curtain, call light, clean environment. However you want to do it. But after you've done all that, you're going to go clean your hands. Now, once you've cleaned your hands, should you go back to the patient environment? Cooties. If you've washed off all those patients' cooties and you go back to the patient environment, what are you doing? Yeah, you're re-exposing. Absolutely. You are now cootied up all over again. So if you go back, if you realize you didn't get the patient call light, you're at the sink, washing your hands, thinking about your scale, and you realize, uh-oh, I didn't give them the call light. Don't ignore it. They noticed. I guarantee you they noticed. So, and you have to, go back to the patient, give them the call light, but don't forget, you now have cooties again. You got to go wash those cooties off again. So make sure you get everything done before you wash your hands. And then after you've washed your hands, if charting is required, that's when you would chart. Okay, good. Why can't you chart at the beginning when it's still fresh in your mind? Like if you're taking a pulse, that is a long time to remember a pulse, right? Thank you very much, Mr. Jones. Here's your call light. Is there anything else I can get for you? Are you comfortable? Want a magazine? Here's your call light. I'm going to open the curtain. I'm going to go wash my hands. I got to remember that number through all of that. And then finally, I can write it down. That's a long time to remember a number. Right. Right. All day. And goes in and out of every patient's room, contaminated all day. But even worse, it's probably going to go home with you. It doesn't stay at work. If it did, that would be one thing, but this doesn't. It's going to go home. You're probably going to take it out of your pocket, throw it up on your kitchen counter, which is where we put everything when we get home. And now you got work germs at home. And remember, these are not Walmart germs. These are germs that made somebody sick enough to not be home. You don't want those germs in your home. Good. So we've just reviewed everything that we learned in the first week. We did range of motion as well, yes. So are you guys all good with that? Can I build on that? Do you have any questions? Okay.
During the test, like you got to get the light, color, you have to wash your hands before give the light
You're going to get the light and then go wash your hands after.
after. So I have to wash before I give the light.
No, because you're working with that patient.
Okay.
So that patient is surrounded by their own cooties, and that's okay. That's their cooties. Just like you have your own cooties sitting there, and that's okay. I'm over here. I'm not touching your cooties. But the minute I go over and touch your stuff, if I touch your can or take your pulse or whatever, now I have your cooties. Should I take those over to her? Does she want your cooties? Probably not. So I need to wash my hands to get all of your cooties off before I come over here to work on her. Okay. Now, if I go over to the sink, wash my hands, and then come back over and touch your can again, I've re-cootied up. Okay. Good. And guys, the old kindergarten circle, circle, dot, dot does not work in healthcare. You guys remember the cootie shots in kindergarten? No? You guys didn't do that? Yeah. Dot, dot, now you got your cootie shot. Yep. Yeah, that does not work in healthcare. There isn't a pathogen out there that recognizes that, so doesn't help us. All right, so the first thing I'm going to do is go over glove removal, because we did not get to that on Wednesday.
And mouth.
Yeah, we have to do mouth care as well, but let's look at glove removal. Is there anybody in here that is allergic to latex? Okay. Okay. Just don't want anybody to stop breathing. Please. We talked about CPR today, but I'm sensitive too. I just get like a little like have on for a while. Yeah, yeah. I'll turn red. I'm not gonna keep them out very long. All right, go ahead and put your gloves on, please. Okay, the first thing about wearing gloves, first thing you need to know is your hands are going to do things without your permission all the time. Your hands are like unruly 2-year-olds. They get into trouble. And you won't even realize it, but your hands will touch things. So when you have gloves on, our whole goal is to keep our hands in sight. So when I put gloves on, you'll always see me do this. Like I hold my hands. I keep them from touching things, because otherwise if my cell phone rings, my hand will go down there to check it without me thinking about it. Now, if I've got blood and goo and all kinds of stuff on these gloves and I go down to pat that cell phone to see if it's there, what did I do? Oh, absolutely. Absolutely. So when you have gloves on, you have to treat your hands like 2-year-olds. Keep them in sight and together, because otherwise they will get into trouble. Once the gloves are used, once they're contaminated, once you've done to the patient whatever it is you're going to do to the patient, and then we have to take the gloves off, there's a certain way you have to do this. So dirty glove can touch dirty glove all day long. This is fine. I don't want that dirty glove to touch my skin though. That's not fine. So in order to take this glove off, I'm going to pinch up. I don't want to go under. If I go under, this dirty glove is touching my skin. So I want right here at the base of my palm, I'm going to pinch up and pull that off inside out. And then I'm going to wind it up in this hand. That way it's not like, you know, waving around, contaminating stuff. I've got control over it. Now, skin can touch skin fine, but I can't touch that glove. So if you do this, you've contaminated yourself. Yeah, you want to go underneath, and pull that off. So one inside out glove is inside the other inside out glove. Now you can take these home and clean your bathroom. Gloves are at a premium right now. You might want to keep them. And then you can throw them away. Is that good? Anytime you take gloves off, you need to assume something got through. Something got through. So you want to make sure that you're washing your hands at some point after, but it doesn't have to be immediately. If I need to take the privacy blanket off, I can. If I need to give the patient call light, I can, because remember, they're cooties already in their environment. But can I walk over to that patient and give them a call light? Remember, we don't want cootie transfer. Okay. Yeah, keep your cooties to yourself. All right, any questions? You guys understand glove removal? Okay, so turn in your skills book to page 66, please. How do we know what to do with each patient? Just go ahead and read the care plan at the top of the page, please. All right, so this care plan is fairly straightforward. It says a resident with natural teeth is lying in bed and needs mouth care. The resident is not able to provide their own mouth care. That's about as simple as you can get. They need their teeth brushed. They can't do it. Go do it. But it says they're lying in bed. Is that a safe position? So what do we need to do? Yeah, I need to get them sitting up somehow. But some patients, you may actually be able to get sitting up on the side of the bed. That's ideal. Some patients won't be able to sit up on the side of the bed. You'll have to put the head of the bed up. Okay. This one doesn't tell us which way. So we're just going to go with the safe way and put the head of the bed up. But when you get the head of the bed up, show you something. I'm going to show you what the mannequin, just so you guys can see. When you put the head of the bed up, that pillow that's behind her head is pretty comfy right now because it's supporting her head and neck, right? When I put the head of the bed all the way up, that pillow is actually going to push her head forward a little bit. So this takes a long time, guys, but the beds move super slow on purpose because we don't want to make somebody like dizzy or nauseous by moving the bed fast. So these things take forever. We could play checkers in the time it takes to put the head of the bed up, or at least a game of tic-tac-toe. This takes a long time. But it's not like a cartoon. This thing isn't going to fold in half. It's not going to eject the patient. It's not going to do anything like that. It's just going to stop moving. So even though I'm still pressing the button, the bed is no longer moving. Okay. You need to get it to the full upright sitting position. Don't, for the test, I've seen this a lot, right? So I'm going to put this back down for a second. So I've seen this a lot. So somebody's assigned to do mouth care. They come over, they're going to hit the head of the bed and it's going up and they go, oh, are you comfortable? Okay. This isn't about comfort. This is about safety. That is not a safe position. This needs to be in the full upright sitting position. So until it stops. Now, this pillow is gonna kind of push her head forward a little bit. It's much better if you have them lean forward. Ms. Jones, can you lean forward for me? And we're gonna slide that pillow down behind the back. See how that sits her up a little bit more? Now, if she's a mannequin, her head's gonna come back. But if you have somebody that has a larger tummy or maybe an abdominal incision or something like that, this might be a little bit uncomfortable because it puts a lot of pressure here. So you can just take the pillow out from behind their back altogether, lay it at the bottom of the bed. That's fine. But what you don't want to do is leave it behind the head. Good. Now, if you put the head of the bed back down, we have to remember that we did that to the pillow, because watch what happens. If we put the head of the bed back down, that pillow is going to end up under her shoulders. And that can be awfully uncomfortable. So Ms. Jones, can you lift your head up for me, please? Okay.
So should we do that before we put it down? Or
I would do it before. Yeah, that way the pillow kind of stays where it's supposed to as it's going down. Mannequins don't demonstrate this as well. If you do it on a real person, you'll really kind of get to see where that pillow ends up, and it's just not very comfortable. So if I know I'm going to have to put the head of the bed up for safety, this care plan says patients lying in bed. I know I have to put the head of the bed up. So I know I have to touch this controller. So now we got to figure out when we want to do that, right? Do you think this controller, who gets to touch this controller? Everybody. It's out there in the open. So patients, visitors, staff members, anybody. Do you think that controller is clean? So it's kind of like the curtain, isn't it? So when do we want to put the head of the bed up? Before we wash our hands. Everybody good with that? You'll forget. You will. Because this is one of the few skills you actually have to put the head of the bed up before you go wash. So you're going to get so into your opening, you're going to know it. Knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm here to brush your teeth. Is that okay? I'm going to close your curtain, go wash my hands. You'll get over to the sink, you'll be washing your hands, and you'll realize, uh-oh, I forgot to put the head of the bed up. So there's an easy out here. Easy. If you realize, if you're over here washing your hands, and you realize, uh-oh, I didn't put the head of the bed up, just grab a paper towel at the end. You know, when your hands are clean, you use that paper towel as a barrier to put the head of the bed up. So there's an easy fix for this if you forget.
But I'm supposed to not touch them without washing my hands.
Yeah, I know. This can get a little bit confusing, yeah. You can wait until after you wash your hands to lean them forward and put the pillow down.
And I just do it with towel.
And that's fine. Yep, that's fine. Well, put the head of the bed up
No, yeah, I'm saying. but then-
before you go wash your hands. Then when you get back, you can lean them forward and put the pillow down. That's okay. You can do that. But so this is where that's very good thinking. Okay. But this is where we have to talk about something called crossover. Okay. And crossover is a very difficult concept to teach. But it is that single point where clean becomes dirty. Right? We know the single point where dirty becomes clean. That's at the sink when we wash our hands. But there's always a crossover between where clean becomes dirty. Does that make sense? It's called the crossover. And it varies, depends on what you touch, where you are, what you're doing. But remember at the end of the last skill, you had to wash your hands. So you're leaving the room with clean hands. Now you're going to the next patient. You haven't really touched anything. There's been no crossover. So technically you still have clean hands. Okay, does that make sense? Until you touch the controller.
Yeah, that's all right, yeah.
But that controller is in the patient's area, so whose cooties are on it? Theirs, which makes it acceptable. Does that make sense? I know, it's hard, it's a very, when you're talking about infection control, so there's actual nurses, that's their job is infection control. There's a specialty in nursing for infection control, just like you can be a specialty for a midwife or a specialty with family nursing or a specialty with trauma, ER. Infection control is a specialty. So these are nurses that go to school for years to learn infection control. I'm just trying to teach you like high level. But do you understand how deep this can get? This can take years and years of study. I'm just trying to like do the surface on this, but there's always going to be confusion because of the crossover. There's always going to be a point where you go from clean to dirty.
Would that be acceptable, what you just did after washing hands, state test with your value?
Yeah, let me explain to you the state test. The state test does not test you on this. They don't expect you to have any awareness of this. The only thing the state requires of CNAs, knowledge of infection control, is that you must wash your hands before performing a skill, before touching the patient, and after touching the patient at the end of the skill. And if you return to the patient for any reason, you must acknowledge that crossover. You must wash your hands again, or at least say you would wash your hands again. That's it. That's it. That is all they require for infection control for you. That's it. So when you put the head of the bed up, does not count. Doesn't matter. They're not grading it. When you adjust the pillow, doesn't count. They're not grading it. They don't grade it. You can wear gloves for any skill you want to. You can wear gloves for range of motion if you want to. Doesn't matter. They're not grading it. They're grading how you take them off, but they're not grading. So if none of this is on the test, why am I teaching it? That's right. That's right. Even though it's not covered on the test, we are now living in a world that is ruled by infection control. So I need you to have a little bit better understanding. The test hasn't caught up to that yet.
With the crossover, is that considered wheelchairs too?
Crossover is anything you touch, that single point in time where your clean hands become contaminated. That applies to anything. So you guys are already aware of the crossover. You aren't aware that you're aware of it, right? So when we washed our hands and we had clean hands, did we just reach up and turn that faucet off? What did we need? Why? Okay, crossover. Got it? You're already aware of crossover. You're just not aware of the term, but you're already aware that there is a single point in time that you go from clean to dirty. You want to delay that as long as possible. Once you have clean hands, you want to delay that. How many of you guys have ever used a public restroom? Public restroom. Okay, so you go in, you do your business, whatever you're there to do, you wash your hands, and then you probably use a paper towel to open the door. If you didn't use a paper towel to open the door, crossover. You are now no longer clean. Yeah. Yes, absolutely. Absolutely. So if you want a fun activity, okay, this is just something you can do for fun. Next time you go out to eat, Okay, just go to a restaurant, doesn't matter what restaurant. Plan on staying a little bit longer. Order a drink first or two. Okay, and just sit there and watch people come in. Okay, so you want to catch them like when they come in the door. Watch them come in and sit down. And look at all the things that they've touched, right? They touched the door handle to get in. They touched the menus. They touched the silverware. They touched the drink. They touched the seat when they were getting in it. Now, watch how many of those go to the bathroom and physically wash their hands before they eat. Crossover. Are they eating with clean hands? But that's okay, because your immune system needs a workout. It does. Your immune system has to encounter pathogens in order to stay healthy. It's like exercise for them. But in a pandemic, do you think we should be a little more aware of it? That was something I used to teach a class called Health Science Concepts, and that was an assignment that I gave them. You have to go out to dinner. And while you're there, you have to track at least 3 separate couples, 3 separate tables from the time they sit down until their food arrives. How many of those people actually washed their hands, went to the bathroom? Actually, you know, they had to get up and go. And you'd be surprised at the results. Very few, because we don't think about it. We touch the door to get in. We don't think about it. We touch the menus. Who's touched those menus? Everybody. We've touched the chairs. Who's touched those chairs? Yeah, so I mean, you are like seriously contaminating yourself. And as long as you're eating with utensils, it's okay. But if you're picking up that big juicy cheeseburger and some fries on the side, and you use that ketchup bottle, we don't think about things like that. So understand that in a general, routine, normal, day-to-day business, we don't think about things like that. And most of our patients aren't either. So their environment's contaminated with their own cooties. Our job is to try to prevent that contamination from moving from that patient environment to another one. Because patients are comfortable with their cooties. It's okay. They've lived together for a long time. But you're not comfortable with other people's. So the whole goal here is to try to keep those cooties compartmentalized, confined. And that's really what infection control for CNAs is all about. Okay, does that make sense? So the test really doesn't test you deeply on any of this. But if you're going to touch anything ooey-gooey, personal skin or non-intact skin, you do need to have an extra layer on. They will grade you on that. Okay. Good. Do you guys know before 1986-ish, CNAs did not have access to gloves? You did not have access. They were not on units. They were not. The only people that got to wear gloves were surgeons. That's right. Yeah, it was the mid 80s, around 86, 85, 86, 87, somewhere in there. And it's all because of HIV. That's when the change occurred. We had hepatitis way before that. We had millions die from TB way before that. You know, we've had pathogens with us forever, but we didn't have access to gloves until the mid to late 80s. And it's all because HIV came along and we didn't know how it was spread. We just had no idea, none. They were trying to figure it out. Did you get it from people breathing on you? No, that didn't seem to work. Did you get it from people urinating? No, that really didn't seem to do much. Did you get it from blood? Yes, we got it from blood. So we were able to kind of shrink it down, but in the beginning, you just don't know. So you do the maximum protection. Well, we saw that with COVID, right? We didn't know how COVID spread at the beginning. So people were told, wear gloves, wear a mask.
I love the toilet paper.
Sorry, that made no sense to me. Kleenexes, yes, I can see you run on Kleenexes. It's a respiratory disease. That makes sense. But toilet paper? That didn't make any sense to me. Now, I knew the pandemic was over when I saw, well, not just more supplies, but somebody's house got toilet paper in my community. So I knew the pandemic was over when you see somebody's house toilet paper. Right? Okay, we got supplies again. That's awesome. Probably not awesome for them, but you know, we look at the bright side of things. So everybody kind of understand a little bit more about infection control from a CNA standpoint. My job is to make you aware that this patient's cooties don't belong over there. The test isn't grading you really strongly on this, but I would like you to have at least a basic understanding of this so that we're keeping ourselves and our patients safe, but also our people at home. Yeah, that's right, our families. Yeah. So thinking back to the late 80s, one of my first jobs was working with HIV positive patients. This is back when we really didn't know a whole lot about HIV. And I had a small child at home. So when I came home, you know, I mean, that was a very scary time. So I didn't want to expose anybody in my home to this. So I never wore my uniform out of the house. I always waited till I got where I needed to go and changed out of normal clothes into a uniform. And then at the end of the day, I changed back from my uniform into normal clothes. So I'm not taking contamination with me. Now that habit, even though I wasn't, as I went through my career, even though I wasn't actively changing, I always had what I called my go bag in the trunk of my car, which always had a set of shoes, a set of scrubs, and some sort of a wipe I could use to wipe down my skin surfaces if I needed to, if I got exposed to anything. And that's a good practice to have. Antibacterial skin wipes, a set of clothes, and a set of shoes in your bag in your car, because you never know what you're going to get exposed to.
My sister washed her clothes separate.
Mm-hmm. Oh yeah, I always did too. Yeah, yeah, that's a good habit to get into. Lysol has a antimicrobial laundry additive that you can add to. It's in the laundry aisle. But scrub manufacturers, Cherokee or Charisma brands, they actually sell one as well. And I have it next door, but I've been using it ever since the pandemic hit. Every load gets a cap full. Because your laundry detergent doesn't necessarily kill all pathogens. So this is an extra step. You can also do the same thing with white vinegar. Cup of white vinegar. That's what we used to use in the 80s and 90s. Cup of white vinegar. Yeah, yeah, yeah. A cup of white vinegar does a great job.
Okay, well, speaking of pathogens and laundry, hot, warm, or cold water?
So I'm going to tell you the same thing that I said when it came to washing hands, right? In order to kill pathogens, the water has to be boiling. So it doesn't matter. It doesn't matter. Yeah, yeah, that would work. Right, a steam, yeah, a steam, but it has to be a special setting that gets that, whatever you're put, either steam or water, gets it hot enough to pass the boiling point.
So just in my
Regular washers usually don't accomplish that. Yeah, but steam settings will. Steam settings. Oh yeah, yeah. Yeah, it's super hot. But remember, and that's why, you know, a lot of people, there's a great debate about hand washing, right? You have to use hot water. Is it boiling? Because if it's not boiling, it's not hot enough to kill germs. And if it's boiling, you should be washing your hands with it because you're going to have a bigger problem shortly. Like blisters, and then you're not going to be able to perform patient care. Okay. So sometimes we, and that seems to be one of the biggest problems in healthcare is sometimes we have a little bit of knowledge and we think it's the whole picture and it's not. And we end up putting ourselves in danger, just like gloves, right? We thought we knew what we needed to know, but turns out we really didn't. And that's one of the big problems with medicine. All right, so I'm going to show you this skill, brushing teeth. This is not a hard skill. All of you know how to brush teeth. We're just doing it as somebody else. A couple things I want you to pay attention to with this skill, though. First of all, pay attention to me putting the head of the bed up and adjusting the pillow. Pay attention to the fact that I put a towel over his chest, right, to make sure that the toothpaste doesn't drip. You're not timed on how long you're brushing teeth. You're just brush the top, brush the bottom, brush the front, brush the back, brush the tongue. That's all they care about. It's not the mechanics of the skill that they're grading you on. It's all this other stuff. When did you put your gloves on? What did you contaminate your gloves with? Okay. Did you use a barrier or are your supplies dirty? Did you clean the basin out or did you put it away full of saliva and toothpaste? Those are the things they're grading you on. Okay, good. Questions? All right. Can you grab the lights for me, please? My name is Patty. I'm your CNA today. How are you? Good, how are you? Wonderful. I need to do mouth hair. Is that okay? Yes. Okay, I'm going to put the head of your bed up. And then I'll close the curtain and wash my hands and gather my supplies. Okay. We'll get you to a full upright sitting position for safety. And if I can get you to lean forward, please. There you go. Is that more comfortable? Yes. Okay, I'm going to close your curtain and wash my hands now. I'll gather my supplies. I'm going to start with the barrier, and we'll place that on your overbed table. I'm going to get a towel, a set of gloves, a basin, toothbrush and toothpaste, and a cup of water. We'll prepare the toothbrush first. Get it wet. Place a little bit of toothpaste on it and set it in the basin. Mr. Jones, can I place this towel over your chest? Yes. And now we'll apply my gloves. Okay, Mr. Jones, can you open wide for me? I'm going to brush the back on the bottom. on the top. Can you bring your feet together? And stick your tongue out for me. Thank you. Set that aside. Go ahead and take a sip. Rinse your mouth. Let me wipe that off for you. Another sip. Okay. Now I'm going to dispose of my cup, wrapper, and toothbrush. I'll be right back. I'm going to remove the towel and place it into dirty bag. I'm going to go clean the basin and I'll be right back. I'll place the toothpaste in the basin. Use the paper towel to open the drawer. And place the toothpaste in the drawer. I'll clean up my work environment and go throw these items away. Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here? A magazine? Okay, your call light is right here. If you should have any needs, let me know. Can I adjust the head of the bed for you? Okay, I'm going to open the curtain and go wash my hands. After washing my hands, I'll think about my skill, make any corrections I need to make, and then tell the evaluator my skill is done. So at the beginning of the skill, putting the head of the bed up is safety. At the end of the skill, the head of the bed is comfort, whatever they want. They can stay sitting up. They can lay back down, whatever they want. Okay, unless the care plan says otherwise. Questions?
I have a question as far as like the gloves with that. I noticed like you didn't take, like you don't take off your gloves until after cleaning the basin out of the way. So you just do the paper towel as like a barrier?
Right, we're using the paper towel as a barrier. Now, the reason is because that basin has saliva in it. So I don't want to be handling the basin without gloves. But I also know once I clean it,
And you still have those gloves.
then I still have those gloves, and that's where that barrier comes in. Now, you'll notice that as I cleaned the basin, I rinsed it out, dumped it out, and then I set it down in the sink. Anybody notice that? Okay, that's because for the test, we do not have to disinfect. We're not disinfecting anything. We're simply rinsing, drying, and storing. Just like your sink at home. You probably rinse out the big globs of toothpaste. That's it, right? You don't take the Clorox and clean it every single time you use it. So your facility will dictate how they want things done. Every facility runs a little bit different. For the test, that's our facility, is the test. There's no disinfection, rinse, dry, store. But I have to have a system in place that allows you to disinfect as well. So that's why we set it down in the sink, because if disinfection is required, you can't be holding it while you're disinfecting. Okay, so we set it down, disinfect it if necessary. For the test, that step is skipped. And then we pick it up with a barrier. I have you pick it up with a barrier because we're assuming that that is now clean. Okay, so one process works for both disinfecting and non-disinfecting. If I was running the facility, you would be disinfecting everything each time. Because remember, those drawers are dark. So if you're putting something that's moist and that's not disinfected in a dark place, we have warm, dark, moist. And if we didn't disinfect, that bacteria will have a chance to thrive. So if it were up to me, you would be disinfecting. But I don't write the rules for everything. So, any questions? Do you understand how to remove your gloves? Do you understand how to do mouth care? And do you understand basin cleaning? Because that's a whole principle we just learned. So we're chipping away. Yeah, in fact, if you look at the next lesson on page 68, we have a whole different lesson for denture care, which we're going to learn next Monday. No, you're fine. You're right on cue. That video that you just saw is on my website.
Yeah, I've seen a lot of these tests already.
Yeah, it's also in the course. So if you do that online course, you'll get a lot of additional information beyond the video. Okay, so the videos are always on my website for free. The course just takes that video and adds a bunch of stuff to it. Okay. All right, so let's go ahead and take your break. When you get back, we're going to get into range of motion. And we'll see where we are with time. I may have to put off test registration until Wednesday. Or then and after, I'm excited. Go ahead and take a break. Sorry, 15 minutes. Right? 15 minutes.
No, when you raise the bed, after you raise the bed, then you go wash your hands. Right after you raise the bed, you go wash your hands.
Are you talking about like helping the patients off and putting their pillow
I saw
behind
that.
them with
Yeah,
So
you
the
saw that
pillow-
too, right?
so that the pillow
It's
is gonna have
contaminated.
Yeah,
this contaminant? That's a good question.
that was what I was thinking. I
That's
said,
good.
this is like,
I
yeah,
didn't think about
I
that.
wanna ask about it because it's like cross contamination
That's
because
a good question though.
Because,
I didn't think about that.
I was looking, okay, so what's gonna do? Wash my hands first before I touch them or before?
I don't think they're afraid of the cross contamination. That's why.
But would that fall in,
Crossing.
it might, but would that say, like, when you finish with the last station, you wash your hands, and then you're coming into
To the
that
dining.
person's environment,
Yeah,
so the pillow is in their space with their cooties.
yes, that's why I kind of, confused.
I don't know.
I was confused on that one. Maybe, knock knock, can I do this, close the curtain, maybe, and then I go back and raise the bed, maybe?
I don't know.
You
Maybe
can do that, right?
I don't know.
Because you saw that, right?
I saw that.
So I'm kind of confused.
She was asking in the video, you come in knock knock, you raise the head of the bed. And
You touch
as
the pillow.
you're touching the pillow and putting it from behind
From
the
your
head to
shoulder.
the back,
Yeah.
but your hands are dirty.
That's what I asked her when she was doing it with the mannequin. I said, but we're not allowed to touch them without washing our hands.
Yeah.
I feel like it was a
I think it
question.
was, what about, it's not about them,
Yeah, that it's their own cooties anyway, that we're
No,
touching because
because
we
we came
touched.
That's
in,
what it is.
but this
Yeah,
came,
but we were out there,
we out
you
there.
know, and now we're touching that. That's why I
Yeah.
was confused, but I guess when we, in that
Whenever
process,
it's in-
we,
yeah.
I think we should do what, you know, what we think
Yeah.
is clean, you know, maybe hand sanitizer, we can do that before we touch them.
But I think we need to ask her, because I don't want to
Yeah,
go through
because
this.
like you said, since it's in their room, that it doesn't matter if we.
Yeah.
Yeah,
That's
And we
what
because
it
assume
is.
that
they're
our
like,
But we
but,
were outside.
yeah,
though.
but
We
then
assume
we were
we're
Well, we-
outside,
Clean
exactly.
from-
Yeah,
I mean, personally, me, I will probably, you know, wash my hands.
Yeah.
That's why I felt like
Yeah.
I was with a question that still unanswered. So I'm just gonna do the logical thing
I'm
and wash
thinking,
my hands when I'm in the business.
okay, what I think, what I'm thinking is maybe knock knock. Okay, I gotta do this and close the curtain, go wash my hands, then I can raise them, maybe.
No,
Because it's
I would raise it first, then go wash my hands, and then adjust the pillow.
Yeah.
If you're gonna do it that way. But don't, on the test, don't confuse yourself.
Yeah.
Yeah, it's
Yeah,
not,
that's
they're not worried about it in the text.
Yeah.
They not.
Yeah.
You can wash your hands and then come fix it up. They don't care. They're not worried about
Yeah, it's,
Let's go, obviously ask me again.
yeah,
I want to look for her.
yeah,
She's the best. I'm worried about me carrying her, like, uh-oh.
yeah. The test she said you don't have to,
Yeah,
but
but it
that's
depends on the tester.
no, she said this, the tester is, they have to have the same, yeah. She said they're not, nobody's grading them on that. It's the skills that you're raising the bed, you know to wash your hands, you know what supplies, what order, put the barrier, and the supplies down, put the towel on them. Ask their comfort and things like that.
Let me check my drawer if I have the pen. I know I took it all. and-
Do you use the back? Are you using the back? Oh, okay, I'm gonna use the back.
You got some?
Oh, no, that was Rachel. I don't like. I don't like going to the dentist and I don't like having anybody's hands near my mouth regardless. So I know for me, that's gonna be awkward.
Mhm.
So I don't practice on a live human, but I do have a dog.
Mhm.
So I will practice brushing my dog's teeth.
My dog did it before she died. She's about her big teeth and her cleaning. Even at that she was 11 years old and the kid is still only one. But she loved brushing her teeth.
Yeah.
Every time I show the toothpaste, she's like excited.
The dog will be free. Mhm. He's 120 pounds, baby.
Close the thing, and then wash your hands. So it means I'm going in there with some personal, you know, space without washing it, right?
I think they're assuming that you already, your hands are already washed.
No, because it's a wash your hands.
No, but
Because
I know that you wash your hands then before,
no,
but they're assuming that you're coming from washing your hands from the patient you were, like, say you went from her roommate, the
Mhm.
roommate first, when you were finished with the roommate, you'd wash your hands,
mhm.
and then you would go over there, so you're entering the room supposedly with clean
Clean
hands.
hands. Mhm.
And that's supposedly, but you
Yeah,
know
what
that
if
they're
I-
not.
Yeah, what if I
You
on
touch
my
the
way?
cell phone, you have to
No.
scratch your nose.
In a way, I start right here, and, you know, whatever, do this. So that's kind of confused me.
That's what I'm saying, let's just, we're with you.
Yeah. And it feels good on your feet. If you touch these noses.
Yeah.
Sorry, she didn't answer that.
What's that?
I'm so kind of confused about the coming into the resident, brush the teeth or mouth. You come in, you knock, introduce yourself, and everything that you're gonna do. Close. It says
Close
here,
curtain.
first curtain, and adjust the
Side of the
bed
bed, right,
without washing my hands first.
right.
So it means I'm not close to this person with personal space without washing my hands.
You can wait until after you wash your hands to adjust the pillow.
So
That's okay.
then-
You can do that. The test doesn't care. They don't care.
then-
They don't care.
Alright.
They don't care. Because there's, so no matter how you do this, okay? I guess the point I'm trying to get to is don't overload on infection control. You can make yourself absolutely crazy with it. So we're gonna have some general guidelines to follow. But don't overload on infection control, okay? Think about your own home. You keep your home clean, you know, you live there, but it's not truly clean. You might think it is, but it's, you know, I mean, you're touching stuff, your people are sitting on couches, and you may have pets, and, you know, I mean, that there's, your environment is not as clean as you think, because even if you mop, people walk on it, right? So there's always some people are, we shed skin cells, bacteria, we are just walking contamination, okay? Your patients are the same way. So when you're talking about infection control, there's no way to get it 100% perfect, because you are entering somebody else's contaminated space. Make sense? And you're touching a lot of things. So if you look too close at it, you'll make yourself crazy. Crazy. Try not to look too close. The things that are important here is that we wash our hands before, we wash our hands after, so that when we leave that patient and we go into somebody else's, we are going in with clean hands. So if we have to touch them, we have clean hands to do that. Okay. I mean, if you walk into a room and there's an emergency, you may not have time to stop and wash your hands. You never know what's going to happen in the hallway in between patients. So that's why we leave the patient environment having washed our hands with clean hands. So we're always ready for what's coming next.
Yeah, I have to make that.
Yeah. So
Walk into some other room, there's all these patients like standing and not supposed to be standing, so I grab her.
yeah. Yeah, absolutely. Absolutely. You never know what you're going to see in the hallway, or what's going to happen in the next room or whatever. So don't get wrapped up in infection control, because it really can make you crazy, because you are entering another space. Okay. Does that make sense?
Yeah.
If I walk into your home, totally different set of cooties than what I have in mind. So, you know, I'm probably going to want to wash my hands if I'm going to eat with you. Different set of cooties. In my house, my cooties. Okay. I still wash my hands before I eat them, even though they're my cooties. Don't get too involved in infection control, because it really can drive you crazy. Remember, there's that crossover point, and there's always a crossover point. And it usually happens like almost immediately. You wash your hands and then you flip off the light switch. There's your crossover point. You wash your hands and you open a drawer. There's your crossover. When you wash your hands, they're never going to stay completely clean. There's always a contamination. So that's where you can get really, really crazy with it. Try not to get too crazy. Okay. Does that make sense? This can go way, way deeper than I'm making it. I'm just trying to bring it very surface. That's all you're required to know, is just very surface. Low
I'm
level.
working right now, and I'm practicing not using a lot of gloves at work. And then they told me, why you not wearing gloves? I said, I'm trying to send my stuff right now. So I'm at school. I don't want to just put gloves on, you know. I have to use it if I'm, you know, like stripping the beds. That's different. So, okay, because it's different from real world to the school. It's really different.
It is different. You're going to go with your facility policy, though. If your facility wants you to wear gloves in every single room, then that's what you're going to do. But now you're aware of what you're touching with those gloves. And that was kind of the point. The test doesn't require gloves for everything, but your facility may, because your facility may not know how well trained you are. So they're attempt at keeping everybody safe is just have everybody wear gloves. My job is to make you aware that everybody wearing gloves all the time may not keep you as safe as you think it does. Okay. For instance, if you go into the hospital, their policy is that you wear gloves with every patient encounter. Every patient encounter, you have gloves on. Well, that's their policy. We're going to follow it. They write the check. They sign the check. I'm going to do what they tell me to do because they're signing my check, right? That's your contract. Your policies and procedures are always your contract with your facility. So if I go to work at the hospital, I will wear gloves because that's what they want me to do. That's fine. But I'm going to be very aware when I put my gloves on, when I take my gloves off, and what I'm touching in the meantime. Okay, so I want that higher level awareness. Good. Okay. All right, so let's go to page 57. So this is range of motion, hip, knee, and ankle. So a different range of motion. Remember we learned shoulder last week? So this is hip, knee, and ankle. So how do we know what to do with each patient? Care plans. Go up to the top of the page, and the care plan says provide the following range of motion exercises to the resident's right hip, knee, and ankle. Flexion, extension. So one exercise, that's it. And if you remember, flexion extension was up, down. We're going to exercise both the hip and the knee together. One exercise works both joints. So let me explain this. So remember, flexion extension is up, down, right? Up, down. Well, if I raise my legs straight up, the only thing that bends is my hip. This is actually very uncomfortable for most patients because it puts a lot of pressure on their lower back. If they have any sciatica problems, it's going to activate their sciatica, no doubt. Okay, so we don't like to do a straight leg raise. So instead of raising the whole leg up, what we're going to do is bend the knee to the chest like they're walking upstairs. And when I do that, both my knee bends, but so does my hip. It doesn't put the pressure on the lower back like the straight leg raise does. So we're going to exercise the hip and the knee in one exercise, both joints, one exercise by bending the knee and bringing it to the chest and back. Okay, one exercise. Then it tells us to do flexion extension on the ankle as well. That has to be done separate. So that's easy. We just bend the foot forward and back, up and down, remember? Forward and back, like they're stepping on a gas pedal. But I don't want that heel to scrape on the sheet as I'm bending it forward and back. So what I want to do is lift that foot off of the bed. So when I bend it forward and back, that heel doesn't scrape. Good? That's it. Put an opening in front of it. Put a closing behind it. We're not going to touch any body fluids. Our patient is fully dressed, holding onto all of their own body fluids, laying on top of the sheet. So I don't need gloves, no supplies. I don't need a barrier. They're not uncovered or undressed, so I don't need a privacy blanket. So this is about as simple as you can get. Let me get somebody to come lay down in the bed and I'll show you what this looks like. Just go ahead and lay down for me. All right, this is my second skill. The evaluators told me that I could simulate hand washing after my first skill. So I'm going to do this skill while simulating hand washing. The care plan, if I'm not 100% sure which side I have to exercise, where would I go to verify? Care plan. So somebody please tell me which side I'm working on. I believe it's the right. Is it the right? Okay, so remember, I've got to make sure it's her right, not mine. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to do some work on your right leg. Is that okay? Just gonna do a couple exercises. It shouldn't hurt. Okay. I'm gonna close your curtain. Let me go wash my hands, get my supplies. I'll be right back. I have clean hands. So I guess it. I've washed my hands. All right, Ms. Jones, I'm gonna do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay? First thing I'm gonna do is bend your knee up to your chest and all the way back down to the bed. We're gonna do this 3 times. So kind of like you're climbing stairs. Remember, we always lift from below with the flat palm. So below the knee and below the heel, and we're gonna go up and all the way back down. Feel okay? Up, all the way back down. And one final time, up, all the way back down. Feel okay? Now I could raise the bed to a comfortable working height if I needed to, but I'm short, so I don't. Now I'm going to move on to your ankle. I'm going to lift your foot off the bed just a little bit. We're going to press the foot forward and back like you're stepping on the gas pedal. You should feel a little stretch. So forward, back, feel that stretch. Just relax for me. Any pain? And that's number 3. Good. Okay, is there anything else I can get for you on here? Would you like a magazine before I go? Are you comfortable? Here's your call light. If you need anything, just press that blue button. Going to open the curtain. Environment's clean. I would wash my hands now. Think about my skill. Make any corrections. My skill is done. Thank you. That's the skill I would want during the state test. If I got to pick my skill, I don't know. Range of motion, elbow, and wrist, I think is even easier. That one I probably would want. Yeah. Any questions? Questions? Okay.
I have a question.
Yes.
So do they usually do abductors on the legs too as well?
There is no usual. It's whatever that patient needs.
Okay.
So there is no usual. Abductors can get a little bit tricky, especially if you've got somebody with osteoporosis or somebody that's had a hip replacement surgery or somebody that maybe has some bone spurs in their hip. Abductors can get very, very tricky. So you may not ever be assigned to do it. Then again, you might. If you've got a dementia patient who otherwise is healthy, but is bedbound, then yes, you may be doing abductors to keep contractures from forming. So there's no normal, because there's no quote unquote normal patient out there. I've looked hard for a normal patient, haven't found one yet, because they're all different. All of them. I mean, even diabetics, you think all diabetics are alike, they're not. They're not. Some are diabetics from birth. Some are diabetics after a lifetime of eating. Some are diabetics with no complications and a healthy body weight. Some are diabetics with a high BMI. They're obese. Some are diabetics that watch what they eat very carefully. Some are diabetics that don't. So, I mean, there's no such thing as a normal patient. None. So unfortunately, that's the answer I have to give you is depends on the patient. Right? Questions? Good question. Very good question. Any others? No? Okay. All right, so let's go to page 82. How do we know what to do with each patient? Care plans. At the top of the page, it says provide hand and nail care to one hand. One. What if the patient has 2? We're only doing 1. Doesn't tell you which one you get to pick. We don't care. Pick one. If somebody has a big cat scratch on their hand and they are a patient for this, the evaluator will tell you, please do his left hand, not the one with cat scratch. Okay, so they're looking for the minimum possible scenario here. Okay, remember, they are never going to test you on hard. That's not what the test is about. The test is proving that you have kindergarten level skills. That's it. Not SATs, kindergartner level CNA skills.
And that's the reason why I do not accept or see.
No, the reason that most states don't accept Florida is because you don't have to go to school. And they know that. All the tests are the same.
Oh,
The test is the same.
just for the-
Whether, right, they don't require classroom training. Yeah. So yeah, if you're testing in Delaware, it's the same test. You're testing in New York, it's the same test. You're testing in Texas, it's the exact same test. Exact. Same questions, same scenarios, exactly the same test. All prometric testing is uniform across all 14 states, exactly the same. Doesn't matter which state you go to, it's the same test. Now, other states are a little bit different, only in the scenarios. And as we've learned, every patient is different. So they just got a different group of patients is all. Okay, scenarios are all the principles, everything we're learning, exactly the same. Just different patients to demonstrate those principles on. Does that make sense? Good. So the reason that other states don't accept, some do just fine. But the reason some other states don't accept Florida is because we don't have that classroom mandate.
Being this.
Well, even this wouldn't count. That 120-hour class at a college campus with clinicals. That's what they're looking for. And only 12% of all CNA testers in Florida go to one of those. 12%. That's it. Everybody else either watches videos on YouTube. Guys, you would be amazed. You guys are all stressed over the test. You're overthinking this, way overthinking it. You know I have a YouTube channel, right?
Yes, I was reading that some people were saying that they watched, they were a challenger.
Yeah.
took the test as a challenger. But I'm.
They never went to a class. Sure.
I want to be more hands-on.
Right. But understand that there are thousands of people that have come onto my channel and they did not get a book. They did not read. They did not go to class. They simply watched my videos, took the test and passed. So why are you guys stressed about the test?
I just want it to be second nature. I know
Yeah.
a lot of people didn't do it, but it's not gonna be second nature. They
Right.
just watch the video just to.
And they're getting lucky. A lot of them are getting lucky.
Yeah, and I
Yeah.
forget things. I got 3 kids.
Yeah.
I want it to be second nature.
You do. And I would prefer you be here, right? Because I might be the body in the bed one day. And I'd like you to have a little bit better knowledge than just you got lucky on the test, you know. But I say that because I want you to understand that when I say kindergarten level skills, I really mean kindergarten level skills.
It's like just having common sense.
A lot of it. Well, but it's common sense to you now. It
No,
wouldn't
yeah,
have been
that's
common
true.
sense to you a week ago.
No, yeah, that's true.
Now it wouldn't like cross your mind, you know, to not read the care plan. Okay, now you're sitting there thinking in your mind, right? So how do these other people like know what to do? How do they know what to, if they don't understand what the care plan is, I mean, how do they even know what to do? Because I've trained you that the first thing you do is look at the care plan because we've done that now 18 times. So it wouldn't dawn on you to not look at the care plan. But about half the people that you go test with will go, the what? The what? Well, what does that have to do with anything? What is that? I don't know about that. Now, the reason they're going to get lucky is because they watched
That's why I
mouth
was
care.
watching the video.
and then they duplicated it. Okay, so the best way for me to explain this is I have a granddaughter who is the light of my life. I love her. She is a little doll and smart as a whip. Now, at 3 years old, I took a piece of paper and I wrote the number 2, a plus sign, the number 2, a line, and a number 4. She took a little pencil in her chubby little hands and she wrote 2 plus 2 line 4. Does she now know addition? No, she copied what I did. It doesn't mean that she really understands 2 plus 2 equals 4. She simply copied it. It also doesn't mean that she would be able to add 3 plus 3 or 10 plus 10. All she did was copy it. I can't say she knows addition. But if the test was 2 plus 2, she would be okay. That's the problem with people watching my videos, is they copy what I do. They don't understand the care plan. So how effective are they going to be when they get out there? Now, the problem is you guys are going to be working next to these people. So you need to be aware of that. So on testing day, your job is not to teach them. You will confuse them. Leave them alone. Let them do what they're going to do. After testing day, when you're out there working, teach them. Evangelize the world. Everybody should know what a care plan is. And this goes way beyond your coworkers, guys. The patient should know what a care plan is. The family should know what a care plan is. Everybody should be on the same page here. Does that make sense? Okay. That's important, but not on testing day. Don't confuse these people when they're about to test, because if they fail, who do you think they're going to blame? Yeah, the last person that told them something. Don't be that person. And I say that because it's happened. It's happened many times. You'll be sitting in the waiting room waiting, and somebody will say that this will be the conversation. I can tell it because I've heard it a million times now. This will be the conversation. I can't remember how many paper towels you need to dry your hands. Was it 5 or 7? I can't remember. And you're going to say, well, my teacher said it was 5. You're going to say, well, my teacher said it was 7. You're going to say, who cares? It's not graded. Now, you guys are all getting ready to go in and take the same test. And there is dissent in the waiting room as to how many paper towels you need to dry your hands after you. The simplest skill there is, and you guys can't agree on it. And everybody starts to panic. Everybody starts to panic. Oh my gosh, I don't know what I'm doing, and I'm here to test, and what if I fail? And so you need to close your ears and understand that you took Miss Patty's class. You're going to be fine. You're going to be fine. You are going to be fine. More importantly, you're going to be fine out there when you're working, which is my goal. Some of those people will get lucky. They'll pass the test. Good for them. Some won't. They'll fail the test. They can retake it. It's all right. Not the end of the world. But you don't want to be caught up in any of that. Okay? Don't let them raise your anxiety levels. Super important. All right. So one hand. Even if the patient has 2, we're only doing 1. For the test, you get to decide which one unless the evaluator instructs you differently. The instructor may say, just wash his right hand. Because the instructor knows there's something going on with the left. They don't want you near it. Leave it alone. Okay. Says the patient is sitting in a chair at the bedside table and can move as directed. So basically, you got a good patient. You got somebody that can do everything you need them to do. All you're going to do is wash the hand. So this begs the question, why are we washing the hand? If they can move as directed, can't they get up and go to the sink and wash their own hand? Or why am I here? What am I doing? Okay. So you need to understand why you're doing, it's not to get the hand clean. It really isn't. The reason that you're doing this is because nail clippers, you know, the things you use at home, you know, that you press down on and it's got sharp things on it that actually cuts through nail, and that nail is hard. So these are sharp, right? Those sharp items. CNAs cannot use nail clippers because they're sharp items. So if you keep nails filed at regular intervals, keep the nails short by filing them, you never, ever, ever have to clip them. Preventative maintenance versus ignoring it, letting it get long, and then having to clip it. Ignoring it, letting it go long, have to clip it, because with clipping comes the danger that you might clip the skin. And that could be a problem. Okay. So nail care is not really about washing the hand, although we're going to wash it while it's there, you know, because if you ever go get a manicure, you'll notice they always like soak your nails before they clean them and before they do them. Well, that's to get the cuticles a little softer, to get the nails a little bit softer, to be able to file them without tearing them. So that's what we're doing here. We're going to wash the hand, rinse the hand, dry the hand. We're going to file the rough edges and clean under the nails with an orange stick just to get any debris out. And then we're going to put lotion on the hand. That's it. That's what we're doing. And it's preventative maintenance. As we get older, your nails will grow slower. Nail growth slows down the older you get. That's because your energy is keeping, you know, going toward keeping you alive, right? Doesn't have a lot of excess energy for nail growth. This is why hair tends to grow a little slower as we get older as well. So by soaking the hand, washing the hand, rinsing the hand, and drying the hand, you're removing a lot of that debris. Then we're going to use an orange stick to get underneath the nails to get them clean. We're going to use a nail file to file the rough edges. And then we're going to put some lotion on, because as we age, we don't produce as much oil. So our skin tends to be drier as well. So this is all due to the normal changes of aging. Good. There are some other changes of aging we have to talk about as well. But this skill overall is to keep the nails at a manageable length without having to trim them. Good. Questions? So with the orange stick, we're going to use the slanted end, like a scoop, under each nail, and we want to wipe it off on the towel in between. So I'm going to clean under one nail, wipe it off, then under another nail, wipe it off, then under the third nail, wipe it off. Filing takes a different procedure as well. When you file, so if I've got a nail that needs to be filed, I would probably take an emery board like this. Me, I'm talking about me, not an older person right now, just me. I would probably take an emery board and I would go back and forth rapidly. That's what we don't even think about it, right? This is the normal way you use a nail file. That is not the way you use a nail file with an older person, though, because as we age, remember I said that we don't produce as much oil? Well, that affects your nails too, and they become harder and more brittle. So if you go back and forth across a brittle nail, it pushes the nail and then pulls the nail. It pushes and pulls, pushes and pulls. And when it does that, it puts a lot of pressure right down the middle of the nail, and it can split all the way down the middle. And then the nail falls off, and it's really painful. So when we file nails, we always file in one direction toward the center. So instead of taking a nail file and going rapidly across the edge of the nail, I would take the nail file and go in one direction. On this side, toward the center, and then across the top in a straight line. Good? Make sense? Okay. So orange sticks, we use a slanted end, bevel up like a scoop. Nail files, we file in one direction toward the center. But we need to talk about washing right now, because this is our first washing skill, and we have a whole bunch of rules that dictate washing. So go back to page 80. We have some rules to go over. All washing rules are going to be, or all washing skills are going to be done the same way. Doesn't matter what you're washing. If you're washing a hand, a foot, a body, a butt, doesn't matter. All washing is done the same way. First of all, we don't put soap in the basin. And that's because you always have to have water for rinsing. If you put soap in the basin, there's no water for rinsing. Now, some of you are thinking, well, you can get a second basin. Go get another basin full of water, and you have one with soap and one with water, and now you've got rinsing water. Are you really into doubling your workload? Because everything you use, you have to clean and store, and there's no need for that. As long as you're not putting soap in the water, you can use it for rinsing. So instead of putting soap in the basin, we're going to put it on the washcloth. Now, the other reason that you don't want to get a second basin is everything you get, the patient has to pay for. They get a bill. At the end of that hospitalization, they get a bill, and everything they use is on that bill. Every basin, every bedpan, every toothbrush. You know how much they're charging for toothbrushes right now? Yeah, because they paid for it. It's theirs. Yeah, toothbrush right now are averaging $17.50. Oh, this is like way worse than what you can get at the dentist's office. At least at the dentist's office, they're decent. These are like the cheapest toothbrushes around, and they're charging $17.50 for them. So if you throw that toothbrush away every single day, the patient's getting charged every single day for a brand new toothbrush. If you're getting basins out of the clean supply cabinet, everything you get out of the clean supply room, you have to scan with a barcode scanner, and that gets charged to the patient. Those basins run about $38. Yeah. So we need to be aware of this. The best analogy I can give you is, let's say you go to a restaurant and you're super excited, you want to eat there, and they seat you at a beautiful table, but they don't give you any menus. And you ask, well, aren't you going to take my order? And they say, no, here at this restaurant, you get what the chef prepares for the day. Well, okay, sounds like an adventure. I'm up, that's all right. But how much is it going to cost? Oh, we charge you what we think we should charge you. Well, how do I know if I can afford it? Well, that's not our problem. Not our problem. We're going to give you a bill at the end and you're going to pay it. But what if I can't afford it? Well, it's not my problem. You're going to pay it. And if you don't pay it, we're going to send you to collections. And if you don't pay that, we're going to put it on your credit report. And in fact, in this community, they take you to small claims court. Yeah. On Tuesdays, go hang out at the courthouse in Brooksville. On Tuesdays, they have a whole courtroom devoted to medical claims. Entire courtroom every week. Well, this isn't trial by jury. No, this is you, the lawyer for the hospital, and the judge. That's it. It's not a trial by jury. You don't get to state your case. The hospital says you received care, you owe, and the judge says, how would you like to pay? Yeah. So can you imagine getting a bill that's got 14 basins on it? You had no say in that. You didn't get to agree to it. They decided you needed it. They used it. You got the bill, and now you are legally obligated to pay, cash or check. Those are your only two choices, cash or check. That is the state of healthcare. And you need to be aware of that. Most people are not aware of that. The number one cause of bankruptcy in America is medical bills. That is the number one cause of bankruptcy in America. You might think, well, but the old people, they have Medicare and that takes care of it, but they have deductibles that have to be met. So they're paying one way or another. Make sure that you're not the cause of an excessive bill. Interesting side note. You know, a lot of nurses are leaving bedside care, right? Nurses are tired of COVID and tired of taking care of patients. Patients are mean. The number one new job for nurses right now, the number one industry is bill review. Like I can open up a business and tell you guys, hey, if you get a hospital bill, bring it to me. And if I can't reduce it, then you don't owe me anything. But if I do reduce it, I get 30% of whatever I save you. Well, if you're going to save money, you're all for it. So you bring me bills and I go through and I say, nope, they didn't need 16 basins. They only needed one. Nope, they didn't need 14 toothbrushes. They only needed one. Nope, they didn't need this. Nope, they didn't need that. This is overuse of supplies by the workers. And I reduce your bill and I submit that to the hospital and they can't, it's hard for them to argue over that, right? So I have saved you money and now you're going to pay me 30% of what the savings is. This is the number one new industry for nurses. Amazing. Yeah. So we have to be careful not to overuse supplies. Just like you wouldn't want a surprise bill, your patients don't either. So basins are no soap zones. We don't need 2 basins to do this. One works just fine. You have a basin of water. You're going to wet the washcloth, wring it out well, and add the water or add the soap directly to the washcloth. Now we're not going to put that soapy washcloth back in the basin. We'll set it to the side. And then we're going to use that water for rinsing. Make sense? Okay. Rinsing water might have a little bit of soap in it, but it's not nearly as overwhelming as soapy water. You can still use it for rinsing. Good? Make sense? Okay. So our first rule is basins are no soap zones. Now we kind of have to get into just a little bit about the changes of aging. We already talked a little bit about how your nails get more brittle and they grow slower. We talked about how skin doesn't produce as much oil, but there's a whole nother change that occurs in people. And that's that the layer of fat underneath their skin, between their skin and their muscle, shrinks and eventually goes away. And if you've ever seen an older person's arm, I'm talking about a really old person, you know that it's like you can see their veins right under their skin. They're like big, ropes right under their skin. Well, that looks different from your arm, right? If you put my arm next to my grandmother's arm, they're going to look different. And that's because I have that layer of fat underneath my skin still, although I am losing it. It is starting to go away. I'm starting to see aging changes in me. It doesn't make me happy. But I still have that layer of fat. Now, why does that matter? Anybody know what body temperature normally is? Do you guys know what?
96.
Okay, it's 98.6 is normal. Okay, 98.6. Guys, think about that. 98 degrees. If you walked outside and it was 98 degrees, what would you think about that temperature? It's hot. But you reach over and touch her, she is 98 degrees right now where she sits. 98 degrees. And if you drop down below 94 degrees, you die. Die. If you drop below 96 degrees, you're suffering from hypothermia. Below 94, you can die. That is crazy. That is hot. But air temperature is not that hot. If it was, we'd be like, oh my gosh, it's 98 degrees and it's hot in here, right? So air temperature isn't that hot. We're comfortable in like the 70s, 74, 75, somewhere in there. We're very comfortable. Some like a little cooler, 72, but we're comfortable in the 70s. So there's a huge difference between 70-degree air and 98-degree humid. Big difference. You take something hot out of the oven and leave it on a counter, it's going to cool down to room temperature. Every time. Things don't spontaneously stay hot. Air temperature cools it down to that temperature. So that means this air is trying to cool you to 72 degrees. And the air is working hard to do that. Your body, remember, you die if you're below 94. Die, dead, die. So your body has to work hard to keep your temperature up to somewhere around 98 degrees to keep you alive. That means that your body has to produce heat. And it does that by you taking in calories and burning them with metabolism. That's how your body stays warm. Good? Everybody with me? Now, that takes a lot of energy. It takes a lot of energy to keep you at 98 degrees. In fact, the majority of the calories you burn is to produce heat. That is the majority of the calories that you burn is to produce heat. So if you don't have a method of conserving some of that heat, your body has to work even harder to continuously burn. Your body has a way of preventing heat loss by having fat under your skin, like a wetsuit to hold in that body heat. That fat layer also blocks out some of the air effect. So even though the air is trying to cool you down, it's not as effective because you have a wetsuit on that holds your body heat in and blocks out outside air temp. Make sense? That is super important. That is one of the most important jobs your body has. Most important job. Now, as we age and we lose that fat layer, we don't have that protective mechanism. So now outside air can have an effect. It tries to cool us down. Inside temperature, that heat we're producing radiates away. So the way we perceive temperature and the way an older person perceives temperature are going to be two totally different things. Could not be any closer if they tried. So have you ever walked into an older person's house and it's hot? You're like, Grandma, it's like 80 degrees in here. Let's turn on the air. And they're like, oh no, I'm fine. It's comfortable. Well, that's because if you make it too cold, that cold is trying to pull down their body temperature. They need it warmer to maintain. This is why your little old ladies sitting in a hallway are all wearing sweaters and shivering. And you're like, oh my gosh, how can you be cold? It's hot. That's because they do not have the method to keep their body heat in and block outside temperatures out. That makes sense? Now, this is going to affect us with bathing, because just like air temperature is going to feel different, water temperature is going to feel different, because they don't have that layer of protection between the true temperature and their nerves. So when you're feeling water and you think to yourself, oh, that water feels fine, your patient may not agree. It may feel very hot or very cold to them. You are feeling it through a wetsuit. They are not. So when we get water, we're going to check it with the inside of our wrist, which is as close as you can get to what your patients are feeling. It should feel warm, not hot, not cold, just warm. And then once we get water in the basin, we're going to take it over and ask the patient to check it. Because just because I think it's comfortable doesn't mean my patient, who doesn't have a layer of protection, is going to agree. So we're going to ask them, would you like to check the water temperature, please? Is it comfortable? That is a must do for the state exam. If you do not ask your patient to check the water temperature, you will fail the test. Because it's not about you, is it? Who's it about? Patient. So it does not matter what you think that temperature is. Nobody cares. Not a single person in that room is going to care what you think that temperature is. But they will care what the patient thinks the temperature is. So for mannequin skills, if you're doing any skills on a mannequin, like partial bed bath, peri-care, catheter care, you are going to ask that mannequin to check the water temperature. But it's actually the evaluator that's going to be sticking a finger in there. Make sure it's warm, not hot, not cold, just warm. Okay. But for this skill, we're doing it on a live person. If we look at the bottom of the page, page 82, you'll see this is being done on a live person. So that means we're going to ask them, would you check the water temperature, please? If they say it's too cold, what are you going to do? Warm it up. Don't argue with them. It is not too cold. I just checked it. It's perfectly okay. Quit being difficult. You're going to say, oh, I'm so sorry. Let me go warm it up for you. So our rules are, whatever we wash, we rinse. Whatever we rinse, we dry. And I know that's very simplistic, and you guys are all rolling your eyes. And of course we do. You wouldn't do anything else. It's what we do in the shower. A 3-year-old knows this. But when you're doing this on another human, you will forget a step. You will. You will. You just will. So you need to say it. Whatever I wash, I rinse. That keeps track of where you are in the process. Whatever I rinse, I dry. You have to keep track of where you are in the process, because if you forget one of those steps, you will fail. Right? Nobody is comfortable with soap on their skin. It dries out, it gets itchy, it dries the skin, it can cause cracks and fissures to form. And nobody is comfortable sitting out there with a wet hand, air drying. Remember, it's not about you, it's about the patient. I've had lots of people come to me and say, I don't understand why I failed. I just forgot to dry. It's not like they died or anything. No, they didn't die, but were they comfortable? Aren't they paying for your services? It's like going to a restaurant and them not giving you your plate of food. Well, I gave you your drink. Not what you're paying for. Remember, these are paying customers, guys. They are paying. So while we're doing this, the washing and the rinsing and the drying, we want to try not to get our surface wet. So in this case, we're working on a table with a barrier, but we want to try to wring the washcloths out really well and not get the surface wet. Other skills will be in the bed, like partial bed bath. Wring the washcloths out. Try not to get your surface wet. Make sure it's protected with a barrier or a towel or something, right? Try not to get your surface wet. And then anytime we apply lotion, we're going to warm the lotion up in our hands and apply it to the skin and then wipe off the excess. Only so much is going to be absorbed. And then whatever's left is going to lay on the surface of the skin, and it's very uncomfortable, but it's also a safety issue. So when we apply lotion, we warm it up in our hands and then we wipe off the excess. Now, some of you will go onto YouTube and you'll view some videos where they put the lotion in the water and let it bob around. There's two big problems with this, actually three. There's three big problems with this. First problem is that water is not warm enough to warm that lotion. Remember, it's warm, not hot. The second problem is that even if it does warm lotion, it's only warming the very outside of the lotion, which is, you know, like right by the bottle, you know, the bottle barrier part. The stuff in the middle is not, the heat's not penetrating to that. And when you squeeze the lotion out, what's in the middle is what's coming out. So it didn't do a thing. The third problem is you're contaminating the water. You don't know where that bottle has been. So putting a bottle of lotion into a basin of water does not accomplish what you think it's going to. So the best thing to do is squirt it out in your hand, rub it together, and warm it up. That works. And then wipe off the excess. Now, let's think about gloves for this skill, okay? And I'm going to give you your patient. Your patient is an individual with intact skin sitting in a chair at the bedside, and they are fully functioning. It's one of you guys. One of you guys is the patient, right? So no body fluids, no personal skin, no non-intact skin. Do you need gloves? No. Now, let's say that this is a dementia patient who digs in her butt. Do we need gloves? Yes. Gloves are not skill specific. Gloves are patient specific. So for the test, you don't have to wear gloves. If you want to wear gloves, it's fine, you can. You want to wear gloves, knock yourself out, no problem. But you don't have to for the test because you're not getting exposed to anything. You're washing your hands before, you're washing your hands after the skill. No need for gloves. Okay, good. Questions? Easy, right? Easy. All right, let me show you the skill because it has good close-up. I'm going to show you the video that has good close-ups. This is not a long skill. I think that the page tells you you have like somebody with your level of experience should be able to do it in 11 minutes. Yeah, it doesn't take that long. See here, my video is just over 6 minutes. So less than half. Or just right around. Wonderful. I need you to do hair and nails are on one hand. Is that okay? Yes. I'm going to close your door for privacy. Let me go wash my hands and then I'll gather my supplies. Okay. Okay, we're going to start with the barrier. So I'll place the barrier on the table. That will give me a place to set your plate suffice. Gather a basin, soap, and lotion. An orange stick and emery board. 2 washcloths. And a towel. Gonna go get some water in the basin. Okay, would you like to check the water temperature, make sure it's okay? Is it good?
Yes.
Okay, you can submerge your hand in there if you like.
Okay.
And I'll bring that tray a little bit closer to you. Is that comfortable?
Yeah.
I'm gonna place the washcloths in there. And we'll put one of the washcloths and use it to get your hand wet. I'm gonna place your hand over here on the towel. Place it to the washcloth. And now we'll wash all surfaces of your hand, including in between the fingers and this area between the thumb and the hand. Going to turn your hand over now and wash the palm of your hand. Now we're going to place your hand back in the basin to rinse. Okay, I'm going to bring your hand over here to dry. Then I'm going to turn your hand over. And I'll take the orange stick and I'm going to clean under each nail. Just cleaning the edge. Does that hurt?
Yeah.
Wipe the orange stick on a towel in between each finger. And now I'm going to file any rough edges. So I'll file from the outer edge to the middle. Check each nail for the rough edges. And now we can apply lotion. So I get a little lotion, pour it over my hands. Apply it to all surfaces. Feel good?
Yes.
Now wipe off the lotion. How's that?
Great.
Wonderful. I'm going to place my soil limits in dirty linen container and then clean up my workspace. Okay, on the way, we'll pick up the soap and the lotion and place them in the basin. We'll use the paper towel to open the floor. These items will get thrown away. Okay, so now, are you comfortable?
Yes, ma'am.
Can I offer you a magazine?
Okay.
Is there anything else I can get for you all here? Okay, your call line is right there. Please use it to call me if you have any. I'm going to open your curtain and wash our hands. Okay, the steps of my skill, make any corrections, and then tell me about where my skill is done. Okay. Any questions? Also an easy skill. Once you understand the rules, the washing. So we're going to see more washing skills going forward. Okay. So you saw basin cleaning again. So we've seen it twice today. And again, you're going to see it moving forward because anything that we wash, we have to clean the basin for. So that's a very common thing that you're going to have to do over and over is keeping those things clean. All right, so we're going to move on. Does anybody have any questions about what we've gone over so far? We're going to move on to blood pressure now. So go to page 38. So the first thing that I want to tell you is that blood pressure is not tested on the state exam. So you will not have to demonstrate this skill for the state test. So we're going to learn it because you need to know how to take a manual blood pressure. But it's not something that you're going to do for the test. And that's a little bit important because it takes some of the pressure off. Most places use an automated blood pressure cuff. You just put the cuff around the arm, press a button, it gives you numbers. It's a great thing. But if that machine gives you an abnormal reading, we always have to double check it manually because we don't know. I mean, if I take your blood pressure and it tells me that it's 180 over 112, and that's high, I don't know, do you really have high blood pressure or did my machine just malfunction? The only way for me to know is to take it manually and see, you know, is your blood pressure really that high? Because I don't want to treat you if it's the machine that malfunctioned. Okay, that's not going to help. So we double check blood pressures manually if a machine gives us an abnormal reading. Most places, though, it's very sad because a lot of people don't know how, a lot of people in medicine don't truly know how to take a blood pressure. And it's one of the skills that they kind of fake it. And this is not a skill you should fake, ever. If you don't get the numbers, it's okay. Go tell the nurse, hey, I tried to get a blood pressure. I can't hear it. Can't get the numbers. 30-something years of experience, have blood pressures I can't hear. So I may grab you and say, hey, I need you to listen to a blood pressure because I can't hear it. It's just too faint. There is nothing wrong with that. That is ethics and integrity. Me making up some random numbers because I can't hear it is not ethics. It's scary. Yes. So, you know, we own the retail store next door, right? I sell blood pressure cuffs and stethoscopes. And about a year ago, I actually have this on video because we have video over there. Guy comes in, he's buying scrubs, his girlfriend or wife, the woman that's with him says, hey, don't you need one of those things, the listening things, pointing to the stethoscopes. And he says, yeah, mine's broke. She says, well, you know, you should look at that. You know, you should get one. He says, nah, I just make up numbers. If they're fat, I give them high blood pressure. If they're skinny, I use low numbers. So here's somebody currently working that just makes up numbers. I mean, why do we even have a healthcare system? I can do that from here. I don't even need to be next to the patient to make up a number. Right? So don't be that guy. I actually had a personal situation with this. I have a kidney issue that makes my blood pressure go very high for short periods of time. And when I say very high, I mean scary high. And when it goes high, I mean, I can usually feel it because there's something very wrong. And I take my blood pressure and I have to get a specific medication from from the doctor to get it to come down. So I called up my doctor. I need to come in. I got some high blood pressure issues. I need to see the doc. So they get me in, and medical assistant, brand new, absolutely. She puts me in the room, finds out what medications I'm taking, does my height, weight, and all that. And she takes a blood pressure. And so she inflates it up to like 140 and then deflated it. Woo! I mean, really fast, goes all the way to 0. And she wrote something down, and I said, what's my blood pressure? Now I knew she didn't get it because my bottom number was at 160. She didn't even go up to that point, right? So I knew she heard nothing. She says, oh, you're fine. You're 112/70. You're perfect. I didn't say anything. Doctor comes in. He says, what are you here for? I said, blood pressure. He looks at the chart. He says, you're fine. I said, no, I want you to take it. He says, why? I said, because she did not get my blood pressure. And I said, I know what it was. I took it before I came. So he took it, didn't get it, took it again, didn't get it. Third time, he went way high. And my blood pressure was 240/160. Which I have episodic high blood pressure, but when it gets like that, it's scary high. And if I don't get treated, I could suffer stroke. So he said, why did she say it was this? I said, she did not take the blood pressure. You've got some training issues there. So if I had been anybody else, he would have just looked at the chart, let me go, and I could have gone home and had a stroke. What we do matters. It matters. Integrity in this industry is essential. If you don't get the blood pressure, you need to say, I can't get the blood pressure, and get somebody else to check it. Okay? It's not a failing. That's integrity. Does that make sense? So now that you understand the importance of this, we're going to go through what a blood pressure is and how to take it. So if you look on page 38, we actually talked about this a little bit on Wednesday. Our heart squeezes, pushes out a wave of blood. That wave pushes the one in front of it. That one pushes the one in front of it. What we did when we took a pulse is we pushed down on the artery so we could feel those waves. Right? You guys remember that? We felt the waves moving through and we counted the waves. And that told us how many times the heart had beat. Blood pressure, same waves. Same waves inside an artery. That doesn't change. Heart squeezes, pushes out waves. But what we want to do now is figure out how much pressure is inside the artery when the wave is moving through and how much pressure in between waves. So think of it this way. We have a garden hose. We hook up the garden hose to a faucet. I stand out there and I turn the faucet all the way on, all the way off, all the way on, all the way off, all the way on, all the way off. When the water's on, the hose expands, gets hard, lots of pressure inside, water's moving through. When the faucet's off, the hose relaxes, gets squishier, less pressure inside. And that's all the heart is doing. On, off, on, off, on, off, on, off. And all we want to do is put a number to that. So we're going to close down an artery with a cuff. That's what your cuff is. It is a tourniquet. We're closing down the artery so no waves can get through. We've closed it down. And waves are still backing up over here. They're trying to get through. They're waiting to get through. The heart is still beating, pushing out more waves joining the party, but they can't get through the toll gate. We slowly open up the artery, slowly open the artery, slowly open the artery, and eventually the first wave, which is sitting here waiting, is able to squeeze through. And when it squeezes through, it hits the top of that artery and makes a thunk sound. And we hear that in our stethoscope. Thunk. Well, the artery is getting bigger and bigger because we're letting the air out, bigger and bigger and bigger. And if the first wave got through, the second one can get through too. So thunk, 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 thunk. thunks because now the artery is big and the waves are going through and not hitting the top. So what we're going to do is inflate our cuff, which closes our artery, deflate our cuff, which opens the artery. And we're going to listen for the first thunk we hear. Where the needle is, the number it's pointing to, is your top number of your blood pressure. We're going to listen to other thumps because other waves are moving through. Thump. They're going to get smaller and smaller and smaller and smaller. Thump, 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 thump. And the last clear thump we hear, that's your bottom number. Wherever the needle is pointing, that's your bottom number. And then you're going to listen a little bit while longer just to make sure that was the last one. And then you're going to deflate to 0. And that's blood pressure. You inflate, you deflate, you listen for the first thunk and the last clear thunk. That's blood pressure. Notice I said listen. Blood pressure is all about what you hear, not what you see. Because when you inflate, you're going to see that needle kind of tick as it comes down, kind of ticks. That has nothing to do with blood pressure. That just means another wave joined the party and hit. It's like a concert, right? People in the back shove. That shows people in front of them and everybody else is shoved and somebody hits the stage. That's all that is another wave joining the party, hitting all the waves in front of it. Doesn't mean it's the blood pressure. It's what we hear, not what we see. Now, those thunks have an actual name. They're called Korotkov sounds, which is a whole lot of syllables. I call them thunks. Okay, but they do have a name, Korotkov sounds. Now, that means when you're taking a blood pressure and you inflate the cuff, there's going to be a period where you don't hear anything. You're waiting for the first. So it's quiet. It's quiet. It's quiet. Still quiet. Quiet. Still nothing. Your brain is going to go, oh my gosh, I missed it. I'm not hearing anything. There's something wrong. Turn your brain off. Tell them to go sit down and have a Coke and a smile. All you want to do is listen. It's going to be quiet. What you're trying to do is find the first one. Okay. So you inflate, you deflate. Quiet, 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 quiet. Thump. There it is. Found it. Where is the needle pointing when you hear that thump? Well, if you hear one, you know you're going to hear more. Thump, 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 thump. Oh, where was that last one? See, the problem is the last one doesn't tell you it's the last one. It doesn't say, get ready, get set, here I come, ta-da. It doesn't do that. It just goes thump, thump. Oh, where was the last one? So you have to pay attention to each one as you hear it because it could be the last one. Does that make sense? The bottom number is often very hard for students to get because you don't know it's the last one until there's nothing behind it. Good? Okay, now normal values. Normal. For the top number, between 100 and 119. That top number is called the systolic. That's the point of maximum pressure. So normal is between 100 and 119, and that's in the first column on page 39. Normal diastolic, or bottom number, is between 60 and 79. So what would you do if you got a number outside of those ranges? Tell the nurse. Do we solve that problem? You just tell the nurse. That's it. That's it. Super easy, right? So 100 to 119 on the top, 60 to 79 on the bottom. You need to know those values. You have to know those values. You will have some written questions on normal values. So on page 32, you can see all of the normal values in a graph at the top. And there's a vital sign activity on page 33 that you could do to help you identify normals and abnormals. Good. Okay, a couple things about the patient for this skill. So we just talked about blood pressure from our standpoint. Let's talk about the patient for a second. First of all, you need to ask the patient which arm you can use. Which arm can I use? If the patient has had a specific condition that keeps us from using an arm, this might be, there's a lot of reasons why we wouldn't use an arm. Maybe there's an IV in that arm. We don't want to use that arm. Maybe the patient is undergoing dialysis and has a shunt or a graft implanted in that arm. You don't want to use that arm. Maybe the patient's had a breast removal on one side. You don't want to use that arm. Maybe the patient had a traumatic accident and had rods and plates implanted to hold the bone together. We don't want to use that arm. Maybe the patient had a stroke and one side was affected. We don't want to use that arm. So there's a lot of reasons why we wouldn't use a specific arm. But the good news is you don't need to know any of that. All you need to know is which arm can I use? You ask the patient. Because if the patient's had any of those conditions, they were told, don't let anyone take a blood pressure in this arm. So I'm going to point to you because you were pointing to your arm a minute ago. You, I believe, have had a shunt or a graft implanted. Okay, so you were probably told when they did the fistula, do not allow anybody to take a blood pressure in that arm. So your patients have been informed. All you have to do is ask, which arm can I use? So when you're taking blood pressures on each other in a few minutes, you're going to be asking each other, which arm can I use? And she is going to say, do not use my left arm. It's inactive now. You're not, yeah, it's inactive, but we still want to avoid that arm because it puts too much pressure in there. Remember, we're stopping blood flow going in, but we're also stopping blood flow coming out.
When did you have your transplant? Even if I told them, please don't use it. Same with taking blood.
Yeah. No, they should not. And this is unfortunately a situation where somebody thinks they know better than the patient. You don't know your patient better than they know them. So if your patient says, don't use my left arm, your only response to that is, thank you. Okay, I'll use your right one. And there's no reason why somebody should argue with you over that. None, no reason at all. Because you are a transplant recipient, there is a possibility that transplant may fail in the future. And if you have to have dialysis, we need an active shunt that's or an active graft that's working. If somebody has clotted it off because of some idea they had somewhere, that can have long-term impacts on you and immediate access to health. So we have to be careful. And again, this is one of those situations where initials behind your name can be dangerous because people believe you. So those nurses, you probably said, well, you know best, go ahead. People believe you when you have initials. They think, oh, well, you got more education than I do. You must know more than I do. Be careful with the advice you dispense because chances are it's probably wrong because you don't know the full story. Okay, be careful. Now, if the patient says, oh, either one is fine. Now we like to use the left because there is a blood pressure difference between right and left. And we always want to be able to compare apples to apples, right? So we try to use the left as long as the patient doesn't have a contraindication, a reason that we should use the left arm. So if we have a choice, left is best. If the patient says, don't use my left, then we would definitely go to the right. Good? Make sense? Everybody good with that? Patient's feet should be flat on the floor. So crossed at the ankles like this is fine. Crossed at the ankles is fine. Knee over knee is not. we don't want you to have to remember all that. So we just tell everybody feet flat on the floor. It just makes it easy, right? Everybody feet flat on the floor. And that's how we're going to take blood pressure. Because when you have knee over knee, it traps blood below the level of the knee because of compression. We're actually like closing off those arteries and veins, and that can affect how much blood is in the system up here because we've trapped some of it down here. And that will reduce the blood pressure artificially. Okay, good. Questions? Okay. All right. So let's look at the gauge at the bottom of page 38 real quick. So as CNAs, we only go up to between 160 and 180. So if you look at this gauge, you'll see that the numbers go all the way up to 340. Please don't. Please don't. As CNAs, we only inflate to somewhere between 160 to 180. Remember, we are looking for high blood pressure. That's all we're doing. Looking for high blood pressure. We're just looking. If you remember this, CNAs do normal. You guys remember me talking about that? CNAs do normal, right? Routine tasks on stable patients. If the patient has high blood pressure, that is not a CNA task. Who would have to do that blood pressure? The nurse. If we already know there's a problem, that's the nurse's problem, not us. So CNAs are looking for high blood pressure. We only go up to between 160 and 180. If we hear thumps right away, remember our first thump is our top number, right? If we go up to somewhere between 160 and 180 and we hear thumps right away, we don't know where they started because we're already hearing them. Somewhere north of where we are. We don't know. We have no idea, right? We're going to keep coming down. We're going to try to get that last thump where the thumps stop. And then we're going to go find a nurse and say, hey, top number somewhere over 180. Didn't catch it. But remember, normal is between 100 and 119. So we found high blood pressure. We don't care how high is high. We found it. So now we just have to go find a nurse. Found high blood pressure, find a nurse. You don't need to know the exact number. And that's because if you go over 180, the compression this puts on the arm hurts. Do you know what effect pain has on blood pressure? What does pain make blood pressure do? Goes up. So if we already have high blood pressure and we're inflicting pain, it's making it go even higher. Is that a safe situation for the patient? So don't do that. If you get up to 160, 180-ish and you're hearing thumps, just come down, find the bottom number and let the nurse know, hey, top number's over 180. Because the nurse can't take your word for it. The nurse has to go check herself. So she's going to go over 180 to see if she can locate that top number. So she's going to hurt the patient. Remember I said the only person in healthcare that doesn't hurt the patient is CNAs. It's not us. Not us. Let them do that. Now, the other problem with blood pressure is the more you take it, the higher it goes. Because we're putting compression. We're closing off that artery. And after you do it 2 or 3 times, the artery starts to rebel a bit. And it spasms, and that causes higher blood pressure. So if you're taking her blood pressure and don't get it, and you take it again and don't get it, and you take it a 3rd time and it's a little bit high, and she goes and gets a nurse and I go in there and I do it, by the time blood pressure number 4 shows up, she's already higher than she started. Does that make sense? So I'm not actively getting a real reading because it's artificially elevated. Good? Make sense? So our rule is we try on one arm. If you don't get it, try again. If you don't get it, move to the other arm, if possible. If you don't get that, move to another patient, let the nurse know. Okay, so you should never take a blood pressure more than twice on one arm in a row. Twice on that arm. If you can't get it, move to the next arm. If you can't do that, move to the next patient. Let the nurse know. Okay. So if you look at that gauge at the bottom of page 38, you'll see that we're inflating to somewhere between 160, 180. In this case, it's at 180. And we're going to deflate and listen. And we're going to listen and listen and listen and listen and listen and listen and listen. And we finally hear a thump where that line is. So we've got to figure out what these little lines actually mean, because we have to put a number to that. So you'll see these lines are all numbered in 20s. So you can see right now the needle's at 0, and then you see 20 and 40 and 60 and 80 and so on. The big lines in between are your 10s. So 20, 30, it's not labeled, but that's what it is, the next big line. 40, 50 is the next big line. 60 is labeled, 70 is the next big line. Those little tiny lines in between are 2s. 2s. So if you look at where the line is, says first thump heard here, can anybody tell me what number that line is pointing to at the bottom of page 38? 106. Very good. You guys got that? 106. All right. And then we're going to hear more thumps. Thump, 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 thump. And then we're going to get to a point where we hear the last clear thump. Can anybody tell me what that number is? 66. So 106 over 66 is our blood pressure. According to our normal values, is this normal? And I would kill for that blood pressure. 106 over 66. That is an awesome blood pressure. Awesome. All right, so let's look at page 39. There's a gauge there for number 8. Says first thump heard here, last thump heard here. Can anybody tell me what the blood pressure is? 130 over 90. Everybody get that? Is that normal? So what would you do with that? Tell the nurse. Let's look at the one for 10. I know these are, it's really hard to read because they're super tiny, but do the best you can. What is his blood pressure? 108 over 62. Everybody get that? Is anybody lost? Anybody lost? Okay. 108 over 62. Is that a normal reading? So all we'd have to do is document it. You don't have to tell the nurse. All right. But I want you to remember, so go back to page 38, look at that drawing there at the top of the second column. I want you to remember that we are trying to hear a wave of blood hitting the top of an artery. And that is buried under muscle, fat, and skin. This is not a big sound. If you're expecting big, huge thumps, you are mistaken. This is a teeny, tiny sound. It's a wave of blood hitting the top of an artery, buried deep. So we need to understand that how we listen is going to affect what we hear. And that's what we're going to get to now is our supplies. So those of you who have kits, pull out your blood pressure cuff and stethoscope. If you have an extra pieces, parts thing like this, just put it back in your bag. You don't need it. So the first thing we're going to talk about is your stethoscope. Stethoscope has two ends on it. It has what we call a diaphragm or a microphone, and it has earpieces that go into your ears. So let's talk this end first. Most stethoscopes have two listening surfaces. That means that you have to tell the stethoscope which side you want to listen to. This whole thing watch this. This whole thing turns. The whole head turns. Now, that's going to be a problem because the whole head turns. When you put this in and out of your bag, this thing can flip over. And when you take it out to listen, if it's not facing the right way, you're not going to hear anything. So on the double tube stethoscope, so those of you who have double tubes like this bar here has a little dot. That dot and the big circle should be facing the same way. If not, turn the whole thing around. I'm going to come around and help each one of you because all of you guys have something a little bit different.
Yeah, I will have one.
Okay, it's fine.
It doesn't
So
matter.
yours doesn't, I just want to make sure yours does not turn. Okay, yours will turn. You have a dot here. So you want the big diaphragm to face the same way as the dot. Okay. So yours does not turn. You're good. Yours is different. I'm going to come get back to you in just a second. Yours, you should have a dot. Get a dot right there. Move your dot. So your large diaphragm should be facing the same direction as that dot. So this is good. Yours is a Lippmann. Lippmanns don't have dots. So what you have to do is you got to pay real close attention here. Look through here. See how it looks like a brick wall through there?
Yeah.
Okay. Now,
Okay.
see how it's open?
Yeah.
When it's open, that means this side is being amplified. So we always want it where the opening is on this side, which you can't see through there. Okay. So now let's move on to the earpieces because this is the part everybody gets wrong. Everybody gets this wrong. Most of you have earpieces that are already pre-adjusted, or some of you, but you two can take a nap for the next 2 seconds. The rest of you have to adjust your earpieces. Your ear canals are not straight in. Your earpieces actually have to be turned so they're facing a little bit forward. So the way we do that is we're going to hold right here, like a chin strap, and just turn them so they're facing a little bit forward. See how his are already pre-adjusted? So yours. Okay. So when you put these in your ears, you have to put them in so they face forward. Not like this. Everybody tries to do it like this. This is not correct. They need to face the patient. Because remember in healthcare, everything's about these have to face the. So we're going to open them up and put them in your ears and gently tap on your diaphragm. And it should amplify it pretty good, right? Take them out. Just flip the whole thing around real quick. Put them in that way, put them in backwards, and tap your diaphragm. Turn it back around. Try again. And see if you can hear better. Do you guys see the difference? If you put your stethoscope in the wrong way, you're not going to hear the thumps. Remember, they're waves of blood hitting the top of an artery, buried under muscle, fat, and skin. So if you have your stethoscope facing the wrong way, you're not going to hear the thumps you need to hear. And remember, what we hear is the blood pressure. So this is the most important part of taking a blood pressure, making sure your earpieces are facing the right direction. Good? Questions? Okay. Now let's move on to this. This is your blood pressure cuff. These are not one size fits all. They're one size fits most. Professional cuffs are going to have a white stripe along one end. This is your measuring guide. Yours won't have one because that's a home kit. It's okay to practice with. But professional kits will have the white stripe. This is how you would measure. If I am concerned that this is not going to fit around my patient's arm, so I'm going to borrow you for a second. Can you come up here real quick? Because she's got little tiny arms and I'm concerned that this might be too big for her. So what I would do is have her stretch her arm out. And I'm going to put this underneath her arm about an inch above the elbow. So we're going to lay it under the arm and I'm going to stretch it around. If it wraps more than halfway around her arm, it's too big. If she's got a really large arm and I can't see either corner, if it doesn't even cover a third of her arm, it's too small. This is borderline. We can use this, but yeah, almost too big. Thank you. Okay, so this is how you gauge whether this cuff will fit your patient as you use this white stripe. It should be between 1/3 and 1/2 the circumference of the arm. Now, your gauge itself, the back of your gauge has this little clip. If you press down on the bottom of the clip, the top magically opens. You have a strip on the front of your cuff. If you open the clip, slide it up the strip, it will stay there firmly attached. Now, I know it's got these little prong things on it. Don't use those. Feel how heavy this thing is. If you just hang it there on those prongs, when you're putting this cuff on somebody or taking it off, this can easily fall. And the thing that's right under it is their wrist. We shatter about 400 wrists a year at healthcare by this not being firmly attached. So you want to make sure when you're putting a cuff on and taking it off that you open the clip, slide it up the strip, and leave it there so that it doesn't come off. Now, yours is a little bit different. You don't have, because that's a home kit, that's designed for you to be able to take your own blood pressure at home. So a lot of these features you won't have. You wouldn't want that on the cuff when you're trying to take your own blood, because then you can't read it. Okay. So now below your gauge is a marking. This little thing right here, this little patch. It probably has an arrow that says right arm, left arm. It may even possibly have a line with a circle, either way. But you have a artery marking. Now, let me show you something. Remember, we're listening to a wave of blood moving through an artery, right? So we kind of need to be over the artery in order to hear that. If I've got a microphone right here, you'll hear me just fine. If I put my microphone over here, is it going to do me any good? So we need to make sure that we're putting the stethoscope in the right place. So that means you have to find an artery. So let me show you how to find an artery in you. So we're going to practice on you first. So if you put your arm out, palm up, and make sure that elbow is popped up. Don't get lazy. Don't let your elbow fall. Make sure it's popped up. At the line where your elbow bends, 2 fingers. Remember, we don't use our thumb for a pulse. You guys remember that? 2 fingers. You're going to go on the inside of the elbow. So like right in line with your pinky, inside of the elbow. It's not in the middle. Inside of the elbow, 2 fingers, and put your thumb on the back, just like we did with the pulse. You should feel thumps under your finger somewhere on the inside of your elbow. Does everybody find thumps? Find thumps? Got it? You having trouble? Okay. You're a little too close to the center, I think. Yours is buried. It's right here. You've got a lot, yeah, you got a lot of muscle tissue there. Did you find it? Find it? Okay, find somebody else's. Grab an arm. Find a brachial pulse. This is a brachial pulse. Remember, we found a radial pulse with measuring cord pulse. It's on the inside, like the pinky side. Got it?
No.
No? Okay. We need her arm completely straight. That's the first thing. Got it? Okay. So we could, let me see here. Do you mind if I write on it real quick? Yeah. Okay. So we could, it's possible. Let me have you stretch your arm out. If I found the artery, which is right there, I could put a little X marks the spot. Now I know where to put my stethoscope. Right? Because remember, we want to be over the artery. That's important. If we're listening to a wave of blood, we need to be over that artery. So yeah, I could take a pen and write on my patient, but do you think she wants me to do that? Probably not. So remember this patch that we talked about, right? Remember this patch? This is our X marks the spot. Instead of me taking a pen and Xing it out, what I can do is lay this on her arm, find the artery, line that arrow up with her artery, and then secure the cup. Okay, so you don't need to write on your patients. You have a way of marking the artery right there. Good. Questions? Not so bad, right? Not so bad. Okay, so now we're going to learn to inflate and deflate this cup. So I'm going to pass out some cans. We're going to wrap our cup around the cans and we're going to practice squeezing and deflating to get the mechanics down. I got all kinds of stuff here. I got all kinds of stuff. We're gonna, I actually am going to have to use this one, and I'm going to help you with that just a little bit different. We got one. Okay. All right. So, because yours is a home kit, it's a little bit different. So what we're going to do here. You're going to leave this attached. So when you're putting this on your arm, it just slides up. Here, it's just going to slide. You actually do have a strip and you've got a liner. So, all right, so wrap your cup around your can. You want to secure the Velcro. So it should look like this. And this extra like flap here, just kind of put it around the back and hold that in your non-dominant hand. So if you're right-handed, you should be holding this can in your left hand. Your dominant hand needs to be holding the hand grenade looking thing. Bulb and valve assembly is what it's called. But you want to hold it so that the tube is up, not like this. It doesn't get held like this. Hold it so the tube is up. And you want that little silver dial in between your thumb and finger. You want to be able, it's got to face you. And you want to be able to move that. So you're going to turn this little dial to the right. Righty tighty, lefty loosey. So we're going to turn this to the right just until it stops. Don't tighten it down. Do not tighten it because you're about to loosen it. So just until it stops. And then you're going to pump air into your cup until that needle gets somewhere up to 160, 180. Then you're going to hold that little silver dial and ever so slightly turn it to the left. I mean, ever so slightly. If you turn it too fast, that needle's going to whoosh ever so slightly. And as the needle comes down, it's going to slow down and try to stop on you. So you have to open it a little more. And then it's going to try to slow down and stop. Open a little more and open a little more and open a little more and open a little more. Okay, so it's not a crock pot. We can't set it and forget it. When it gets down to 0, let all the air out. Close your valve, re-inflate. I'm going to come around and show you the rate you should be looking for. This is what your needle should look like. Right here. That's what we're looking for. Should look like a second hand going in reverse. This is what your needle should look like. And then that's what your needle should look like. Second hand and then in reverse. If it goes too fast, you're not going to hear the thumps. If it goes too slow, that arm's going to reach out and smack you. But in order to keep that rate, see how it's starting to slow down? I have to open a little more. See how it's starting to slow down now? I gotta open it a little bit more.
When I did mine, it went like really fast. That mean I opened it too.
You opened it too fast. Yeah, you are in control of that rate. Okay. And when I say little motions, I mean like a hair. Barely touch it. You have more control if you keep your finger on the dial. If you try to open it and then let go, you won't have as much control over it. So when you're holding onto that silver dial, you should hold on. So give it a couple tries. Okay, this can clearly has no blood pressure. So there's nothing for you to hear, and you're not seeing any ticking of the needle because there's no waves joining the party. So this is only going to help us learn how to inflate and deflate. It gets us control as we're doing the skill. And you probably think you've got it down, but you don't. So what we're going to do now is practice on each other a couple of times. And then when you go home over the next couple of days, I want you to go back to the camp and practice inflating and deflating to get that fine motor control. But you're not really going to be able to figure that out until we put it all together. You don't realize just how rough you are yet until we make it real. So what we're going to do now is make it real. Okay, so I'm going to have you three work together. Just a moment, just stay where you are. You three are going to work together. And what we're going to do I'm just going to do this just here. So you'll have to come around this way. Okay. So what we're going to do is I'm going to have you sit down and he's going to take your blood pressure. Okay. And then once he takes your blood pressure, you're going to sit down and she's going to take your blood pressure. Once you've taken his blood pressure, you're going to sit down and she's going to take yours. Okay. Got it? All right. So you three, you're going to be the patient and you're going to take her blood pressure. Once you're done, you become the patient, she'll take your blood pressure. Once you're done, you guys will switch. Got it? Got it? Okay. So when you are taking somebody's blood pressure, their arm should not be hung out there in midair. It needs to be supported on a surface. You also should find the artery. So that means you have to feel for it. Notice it wasn't in the middle, right? If somebody's taking, I'm sure most of you have had your blood pressure taken. They never find the artery. They slap the stethoscope right in the middle of the, it's called an antecubital fossa, that's technical term, but right in the middle of the elbow space. But that's not where your artery is. So you really do need to find that artery and figure out where it is on your patient. But sometimes it's hard to feel. The best advice I can give you is to make sure that arm is extended. So what I want to show you this real quick. Extend your arm out and find your artery. Keep your fingers on it. And then let your elbow relax a bit. It goes away. What happens is that artery sags way down deep when your arm is like this and you can't feel it. You've got to get that artery popped up by getting that arm straight. So when you're trying to find an artery on somebody, if you can't feel it, make sure their arm is fully extended. Okay? Good. Make sure the arm is supported on a surface on your table too. So you guys, you'll have to walk around or just move the table. You can kind of move the table and get through if you want. And then you guys are going to come over here. You're going to sit in this chair. And we're using your right arm. So I've got it positioned properly so that your right arm can be on the table. Okay. So, yep, you're going to come over here and do hers. So your arm needs to be supported on the table. So I want you to come around here. Nope. You're going to continue to face that way. Come over here so that you can reach that arm. Yeah. Got it? Oh, you guys are going to be all thumbs. It's okay.
I still have the experts.
Yeah.
Maybe
That makes it easy. That makes it easy.
It is supposed to be like kind of tight to begin with. Or
Yes, it should be snug. Yeah, snug on the arm so it stays in place.
That's the hardest part. Sometimes is the Velcro. I'm too good because I haven't done it too many times. Thank you for that.
I'm so excited. My niece is having a baby today. So I keep checking my phone to see an update. Let all the air out. There you go. Did you hear the thumps? Did you hear any thumps?
I heard it, but I don't think I called it.
That's okay. All I want you to do right now is hear thumps.
Okay.
Okay.
Yeah.
Good.
I'm just probably gonna I'm kind of ambidextrous, so
Okay. However you want to do it. I can do it with both hands as well.
I heard it, but I didn't like touch them.
That's okay. That's all right. As long as you're hearing, that's what I'm wanting right now is that you hear it. So basically, I want your brain to understand that we have physical dexterity, we have listening, and we have watching, and the brain has to coordinate all of that. And there's a lot going on. And you need one more hand to make it all work. So that's what you're figuring out now is kind of the overview. You're going to go home and practice on your can to kind of fine tune.
Because once I heard it, and then it was like already probably like 20 down. I was like, oh, I'm supposed to count that.
It's okay. It's all right. Go ahead, take it off and switch partners.
Just a light.
Okay. All right. So go ahead and have a seat. Let her take your.
And we put it at like 180, right?
Yeah, somewhere between 160 and 180. Anything over that tends to hurt.
Well, I'm sorry.
This is hard
Right
to
away.
feel. He's got a lot of muscle tissue. It's gonna be. Did you put your thumb on the back side? Right here, but you gotta press kind of deep. If you can't find it, just go ahead. Got it? Okay. It is hard. Sometimes it's really hard to feel. You may not be pressing hard enough. So we're gonna get your arm extended fully. Right here, right under my thumbs. Put your thumb on the back, it helps. Remember, I've got a million years experience doing this, so. You're not going to hear anything because your arteries wide open, your waves are just moving through. You can't hear anything right now. Oh, yeah, you got the fistula there. Yeah, you'll hear a gurgling. That's where high pressure and low pressure mix, and that's what you're hearing is the gurgling mix. As long as it hasn't popped up.
Keep it tight.
Oh my gosh. I know that there is a term. I can't remember the term. That's good. Remember that you want to. Oh, you got the. Okay. Did you hear thumps?
I think I got it.
Okay. All right.
Yeah.
Okay.
Yeah, I was like,
And then-
myself at home, and I was like, yeah, not, that's it. It's purple.
Yeah. So let her take yours.
Okay.
And then we're going to switch partners because I want you to have at least two blood pressures. At least two. We're going to see if we have more time for three. I don't know.
If I did it right, yeah, right, it was like one and two. Doesn't matter.
You gotta let it come down.
Yeah, keep opening it. Keep opening it. Don't let that needle stop. Did you hear thumps? Good. Yeah, just don't let that needle stop. Okay, let all the, yep. Go ahead and take it off his arm.
I got that blood pressure. That difference
Yeah,
won't be higher.
that's what mine is too. Okay, so you're gonna have a seat and let her take yours. You want to have that cuff a little bit higher. A little bit higher. Set the stuff in your ears. You don't have to keep your finger on
I'm scared of myself after going to the gym.
it.
And then I use the one that you just go and sit in there.
Yeah.
Blood pressure is so high. My blood pressure is so high. She's like, you just left the gym.
Yeah, it's exercise induced.
Yeah. I was like, oh, or
Do you drink energy drinks?
sometimes.
Close, yeah, make sure you close it out. Energy drinks can elevate blood pressure as well.
Yeah.
So if you drink energy drinks and work out, I'll take your blood pressure right after.
Yeah. Yeah, energy drinks. So one time I took one, it, like made me all shake. I was like, I'm not going to
Did you hear?
I heard it, but I have to work on the mechanics.
That's fine. Yeah, that's fine. So I want you guys to change partners, grab a new partner. I'm gonna divide you up into groups of 2 now. So let's have you 2 work together and you can work over here if you want to. And then I'm gonna have you trade places. You guys are gonna trade partners here.
When you're learning to not get the needle to go down slow.
Yes.
Okay, because for me, I feel like I'm trying to make this, but it's still.
And that's why I said you'll probably want to go back to your can this weekend just to work on the mechanics of it. So I'm gonna have you. I'm gonna have you, yeah, real quick. You 2 over together, and if you want to come over here with me, you guys will work together. I'm still learning names. When you guys get up and move around, I'm lost because I named the seat.
It don't matter.
Go ahead. It's all right. So let's turn the chair around so your arm can lay on the table. There you go.
I'm being, like, I'm being.
The good patient, yes. No. Okay.
That's what you talk about. Yeah, I heard it. I heard it start and stop.
Very good.
Yeah, you might.
Stay on the high.
Mine tends to be a little bit higher. Don't be surprised if it's like 131.
Yeah, like 130.
Don't be surprised.
That's my money.
Um,
Yeah. Oh, it's like right. You gotta dig in there.
Let's go ahead and finish up the one you're on. Okay, this is really hard to feel.
it's right. Right here. But you have to cut, right, he's got a tendon and a muscle that literally overlap. Oh, so do you see what my fingers do? Pushes that tendon and that muscle out of the way, so I'm gonna go over it. Yeah. It really like.
That's all right.
They think I feel it now. Okay, thank you.
You're welcome.
No, that's all right.
Okay, go ahead and finish up the one that you're on. Keep opening that dial so that needle comes down. Keep opening. Keep opening. A little more. Keep going. Don't let the needle
It's
stop.
easier to hear.
Yeah.
It's easier to hear than
Yeah, I
to
can
find.
hear it pretty good, but.
Yeah, I know mine too.
All right, go ahead and resume your seats. I know I'm keeping you late. I'm sorry. I'm gonna try to hurry this up. Okay. So you probably noticed that you don't have the mechanics down. But it took you kind of putting it all together to realize that you don't have the mechanics down, and that's okay. That's normal. So go back to your cans, work on your fine tuning your technique, and then practice on anybody that you can tackle. Okay, neighbors, friends of neighbors, neighbors of friends, whatever. Practice. Don't get stuck on one person because everybody's blood pressure sounds a little different. So don't get stuck on, one person in your house. You need a wide variety of practice here. Okay. Understand you're not going to be accurate. You're learning. So if you get some wacky number, don't call 911. You're probably wrong. Right? You're learning. But you do need to get some practice here with this. There's no substitute. It takes about 45 blood pressures before you start to get accurate. You are nowhere near accurate at all. but you've got to fine tune it. Okay, does that sound good? You're gonna have chapter 4 for homework tonight. Chapter 4 is unnecessarily complex in the blue book. It is the worst chapter that we have to get through. You are not responsible for knowing what organs are in each body part. That has nothing to do with CNA. Chapter 4 is going to cover that. But what I want you to pay attention to, like we covered a lot of today, what are normal changes that we go through when we age? So when you're reading those sections, what are the normal skin changes? I went through those today, but what are the normal digestion changes? What are the normal urinary changes? You need to know those things. That's what I want you to focus on. Okay, good. Don't get too wrapped up in chapter 4. It's not that, you don't need to know that level of complexity for the test. Those of you who are going on for nursing, you have to do 2 semesters of anatomy and physiology. Trust me, you're going to get way deeper in this than you ever wanted to. That's how I know this is the antecubital fossa. Okay, so sticks with you. All right, I hope you guys have a fantastic evening. Do you have any questions for me before you go? I know you got one.
What is the other side of this?
That is used for lung sounds, which we don't do with CNAs, and you can use it for blood pressure on children. Oh, that reminds me, when you're out there practicing, please don't practice on kids. This hurts little arms. No one under 13. Don't practice on old people either. They've got enough health problems. They don't want to be your guinea pigs. Leave them alone. But between 13 and 80, fair game. If you can tackle them, you should be taking their blood pressure. Seriously, you need a lot of practice. Huh? Oh, yeah. In fact, hide their phone, change the Wi-Fi password until you get 5 blood pressures in. They don't get access to anything. They'll stick around. They'll stick around. All right, guys. I hope that you learned a lot today. That you got what you needed out of today. I will have the recording up on the website later on this afternoon, so you can review the live recording if you need to. Okay. Have a good day. Bye. Don't forget your book.
Oh, thank you. I'm